detect hypoxia right within the brain and measure brain blood flow. Some of these new technologies have to lead to better outcomes. We just need to get the evidentiary support for them. And I think there's some even newer tools that have a lot of promise in head injury. I think we're very close to the clinical application and the acceptance of non-invasive ICP measurements at the bedside. There are some centers in the United States that are now using portable MRIs on their head injury patients. And as Hutch alluded to, now we have handheld devices that can detect extraaxial hematomas. So all is not entirely bleak. And before I get to the provocative part, I did want to talk a little bit about the current landscape. I think that there have been a couple of modern breakthroughs in TBI care. Unfortunately, one of them is supportive care. We are getting better at aggressive pulmonary care, intubating these patients, treating sepsis aggressively and early. And that's led to about a 50% reduction in patient mortality. But again, we still lack a targeted treatment for head injury. And perhaps, highly related has been the Brain Trauma Foundation guidelines. These were the first guidelines ever developed by a surgical specialty. They have been wildly successful anywhere in the world they've been introduced, including New York State. They've been associated with a 50% reduction in mortality, I think overlapping with some of that benefit I just spoke of. I have to say it's been one of probably the greatest privilege of my life. I now oversee these guidelines and really am helping to develop the Brain Trauma Foundation's future guideline efforts. At this point, the Brain Trauma Foundation has amassed a tremendous body of work, over 14 completed guideline documents, many in late editions. We're very close to publishing a new version of the pre-hospital guidelines, and work on a penetrating head injury guideline is underway. Now, I do want to say that as good as the guidelines have been, they have had problems. So as methodology has become more rigorous, there's been a lot of criticism of the BTF guidelines for not being of enough assistance to the physician at the bedside. And that's really been my job to tackle as I've stepped into my role. One of the first things that we did to try and develop something that was a little bit more helpful to the clinician at the bedside, we tried to develop some treatment algorithms. These used to be part of the BTF guidelines, but because they're not inherently evidence-based, they were pulled out of later editions. I called up a respected senior colleague, Randy Chestnut, to help me develop this, and I want to acknowledge Hutch's role in this project as well. We pulled together really over 40 of the world's top experts to help work through a rigorous Delphi consensus process. And this was wildly successful. So we were fortunate to develop 2 sets of algorithms, one for patients that have intracranial pressure monitoring alone, another set of algorithms for patients that have both intracranial pressure and brain oxygen monitoring. And don't have time to go through these, but they've been effectively distilled down to these 2 posters. If you're interested, these can be downloaded from either the Global Neuro or the Brain Trauma Foundation websites. They've been translated into 10 different languages, and hopefully this will get the clinicians at the bedside the help that has been a little bit lacking in some of the recent BTF guidelines. The other thing we've tried to do to make these guidelines a little bit more useful at the bedside, Hutch, with his rescue ICP trial, gave us reason to update the decompressive craniectomy recommendations. And what we decided to do here was to reintroduce expert opinion. These have been basically kicked out because it wasn't a high enough evidentiary level. What we decided to do was right next to the evidence-based rigorous guidelines, we separately labeled a section on expert opinion, making it very clear that this was more of a subjective discussion, but we've had very positive feedback on that, again, a little bit more helpful to the clinician at the bedside. So here's, I think, the fun part of the talk. So these are things that keep me up at night, things that I hope you'll find controversial, and there probably are going to be some people in the room that are better equipped than I am to answer some of these problems. I was really struck a few years back at one of our major neurosurgery meetings. The founder of the Khan Academy presented, and he talked about one's learning being built upon successively on strong foundations. And if you don't get the bottom first level right, well, then you're basically doomed to fail. And as I look at all of these trials in head injury that have failed, I have really started to wonder, could it be that we've got some of the basic tenets of head injury wrong? And I think that really that's the challenge before those of us in the field now, is to try and figure out why is it that all of these trials are failing. So I can't go over many different examples, but I want to share a few thoughts on some really high research priorities things that we may be stumbling over as we try and do our studies. So one of the things that I think we really need to tackle as a high priority in neurotrauma is the issue of cortical spreading depolarizations and depressions. So these were discovered about 75 years ago by the Brazilian Leal. So these are high amplitude, slow propagating waves of depressions and depolarizations. It was initially thought that these were described in the lissencephalic rat brain. It was thought that these couldn't possibly happen in the more sophisticated human brain. But in fact, we now know that they do. In fact, this is the accepted cause of migraine aura, and it is probably also the cause of seeing a white light in a near-death experience as dying cells depolarize. And it's sort of remarkable to me that, we fuss a lot in neurosurgery about seizures, but the reality is that the energy expenditure with the cortical spreading depression depolarization is markedly greater. In fact, for a lot of neurons, when they experience one of these, it can be a terminal event. Now, the problem is neurosurgeons, a lot of us don't have the skill set to really analyze and detect these. I was like a lot of people in my profession, where I sort of buried my head in the sand, but I think the time has come where we really do need to understand these phenomena. And that's especially true because it's now been shown in multiple studies that NMDA antagonists like ketamine are actually effective in treating these. So it's high time that we figured out, do we need to monitor for these phenomena? Do we need to treat them? Now, something very provocative. It's only because I'm very involved with setting the standard of care now that I actually wish to challenge something as fundamental to TBI as the Kelly-Monroe doctrine. So I don't wish to contest the fact that as there's an expanding intracranial mass lesion, there's no question that we squish out CSF and venous blood. But I think that there's certainly some problems with this, and of course it's an over 200-year-old theory. And this, to me, in my books, this is probably the most important figure in all of head injury, and I think it might actually disprove the Kelly-Monroe doctrine, because what it shows is sort of the opposite of what we traditionally think. So this is work done back in the 1960s by Niels Lundberg, and what they did, this was in a time where you could watch ICP spike all the way up to 80 and not treat it. We couldn't do that today. And what they did is they radio-labeled albumin. They put Geiger counters on the side of patients' heads. And what's quite remarkable is that instead of, with these ICP spikes, blood being squished out of the head, it actually goes into the head. You see an increase in intracranial blood volume, and perhaps that is driving the ICP increase. So this is the exact opposite of what we're traditionally taught with the Kelly-Monroe doctrine. I think that probably where this is best described, the underlying rationale for this, it was explained by Mike Rosner. And what he described was vasodilatory and vasoconstriction cascades based on these autoregulatory principles, the idea being that whenever the brain isn't getting enough of something that it needs, it dilates its cerebral blood vessels, that increased blood volume leads to increased ICP. Conversely, and I think very clinically relevant, is that if you can give the brain enough of what it needs, or perhaps more than what it needs, you can actually constrict the cerebral vasculature, reduce the blood volume, and reduce ICP. And I want to show you some examples where I think that's really important at the bedside. So I think autoregulation, which these principles really are built on, we're getting far better in neurosurgery now at recognizing autoregulatory principles. And in fact, in the CBIC algorithms, we now argue that every clinician caring for head injury needs to understand these principles. So what we see here, so typically what we do at the bedside is we look at the relationship between ICP and blood pressure. So like what Hutch showed earlier today, we see that these trend lines are moving in opposite directions. This reflects intact autoregulation. A patient that will do better with a CPP that's higher, around 70 millimeters of mercury. But patients change throughout the course of the care. So here's the same patient at a different time. Now the relationship between that ICP in green and the blood pressure in red it's a direct relationship. So now this patient has deficient autoregulation and actually will do better with a lower CPP, usually around 60. So this is clinically relevant, and I think we're doing better as clinicians at understanding these principles. But this has been a bit unsettling to me to see sometimes some different relationships. And this really goes to that Rosner physiology that I spoke about. So what I want to draw your attention to is the fact that now in that green ICP tracing, we don't really see a relationship between the blood pressure at the top and the ICP, what we see a far stronger relationship between is the intracranial pressure and the oxygen saturation. You can see they're virtually mirror images of each other, and this is despite the fact that the systemic oxygenation never drops below 90%. So it really suggests that the brain in this instance is auto-regulating to the oxygen saturation and not to the blood pressure. And I think a lot of clinicians at the bedside aren't necessarily thinking about this sort of physiology. I can guarantee that if you look at these sorts of relationships in your patients, it won't be hard to find situations where it's actually the oxygen saturation that seems to be driving the ICP. So the last thing that I wanted to talk a little bit about is a final problem that's really driven my work in my basic science lab, and that's the question of perhaps whether autoimmunity to the injured brain and spinal cord that are normally immunoprivileged could potentially be harmful after brain or spinal cord injury. And the thing that has always piqued my interest about this is the issue of a globe rupture. So we know that the eye is a central nervous system structure. We know that after a significant globe injury, you can develop sympathetic ophthalmia, where you develop an autoimmune reaction not only to the bad eye, but also to the good eye. And it can be a reason for ophthalmologists to remove that damaged eye and prevent sensitization of the immune system within a critical window. So obviously in a head and spinal cord injury, I don't think we want to be removing the brain or spinal cord, but I've often wondered if perhaps there could be a role for immunosuppression in some of these patients. Now, one of the things that we know, there's now an FDA-approved blood test based on the notion that we are spilling these immunoprivileged antigens into the peripheral circulation, potentially allowing sensitization. So this blood test has been around since 2018. And so what I wanted to do in my lab was to replicate this phenomena. So what I did is I took spinal cords out of donor animals, mulched it up, injected it under their skin either once or twice into recipient animals, looking to see what would happen in the brains of these animals if we never even touched the brain, we simply inoculated them. What's quite interesting is that to neurologists are very aware of the fact that in ischemic stroke and other brain insults, autoimmunity is a real thing, and in fact this model is very similar to the established workhorse model of multiple sclerosis, the experimental autoimmune encephalomyelitis model. So I'll show you what we found. So in fact, in particular in the animals that were double inoculated, we did see the development of autoimmune antibodies that bound to neurons, and we also saw some that bound to oligodendrocytes. And at both the gene expression level and at the protein level, we saw encephalitis. Again, we never touched the brain, but simply by injecting central nervous system tissue into the skin, we saw an inflammatory reaction in the brain. We also saw upregulation of the neurodegenerative proteins amyloid and tau, and very importantly, we saw a functional deficit. So these inoculated animals had trouble with the Morris-Water maze relative to controls. And perhaps the strongest suggestion that this autoimmune phenomena could be harmful came when we looked for dying neurons labeled with fluorogate B. In fact, in both the brain and the spinal cord, the inoculated animals had higher rates of neuronal death. Ultimately, you know, it may seem like a bit of a crazy idea at this point in time to think about immunosuppressing patients with head or spinal cord injury, but ultimately that could be where this research goes. I think before we even remotely consider that, though, we really need to be thinking about what is the autoimmune response to the CNS in humans. And so what I decided to do is we looked at both, we looked at spinal cord injured patients, TBI patients, and brain tumor patients. And we looked at the autoimmune response to GM1, a myelin antigen. And in fact, in many patients, but not all patients, we saw an increase in the titers of these autoantibodies. Different phenotypes in each condition. We really didn't see the same phenomenon in the brain tumor resection patients. But certainly a basis for the study, and we're very interested in the fact that we see the peak antibody titer around the 2-week time point, which is sort of the margin of that critical window for enucleation in sympathetic ophthalmia. So we think that's a very interesting parallel. What we did find is that the strongest predictor of autoantibody titer was injury severity. So it may be that this is a phenomenon only important in the most severely injured patients. So with that, I wanted to close. I think that we do have new tools to battle TBI, but we really need to spend some time figuring out why it is that we're not advancing. And you know, to be provocative, I'd like to hold out that maybe part of the problem is that there's some basic tenets of our field that we haven't got quite right. So with that, I'll close, and I thank you very much for the invitation.
Thank you, Greg. And you have time for one or two questions. Professor Hutchison.
Greg, fantastic. First half thought-provoking, second half thought-provocative. So that was terrific. Couple of questions. So, I mean, we talked about microdialysis. It's a great technique. It's probably not taken off because the technology is cumbersome. The cortical spreading depolarization is important, but I guess that might be in the same boat. How are we going to, I mean, to measure it's difficult. You're talking strip electrodes. Is there a smarter way that we can try and detect that beyond academic centers?
Yeah, I've talked to some smart neurologists that basically say that even the metal on a bolt is probably something we can tap into to detect these CSDs. You know, it's just very striking to me. You know, one of a lot of this work is being done in New Mexico right now, and they're finding that, you know, after even chronic subdural surgery, they're seeing these events, they're tying them to neurological deficits, and it really asks the question, should we be paying more attention to this?
And the second point is immune suppression, and that may lead to a drug that works in the laboratory. How are we going to make sure that the immunosuppressive drug works in the clinical arena, given the steroid studies? And do we need to think smarter and not go for one neuroprotective agent, but perhaps look at all the pathways, whether it's immunosuppression, excitotoxicity, free radicals, and perhaps a more polypharmacy type approach?
No, that's a wonderful question. And what I would say is that the person that actually has really paved the path to try something like calcineurin inhibitor in neurotrauma is Ross Bullock. Yeah. And his interest was in mitochondrial stabilization. So there really is a couple different reasons why we might think of trying these drugs in these patients. I think my personal interest in this going forward is going to be with some of the new targeted agents like infliximab that have really been game changers in other autoimmune conditions. So that's the next grant is looking at infliximab in head and spinal cord injury.
Great, thanks very much.
Thank you very much, Dr. Harlock. Great to have an alumnus here. And then the fourth talk in our special trauma symposium will be delivered by Dr. Barbara Haas. Barbara is a trauma and critical care physician at Sunnybrook. She's an assistant professor in our department and a scientist at the Sunnybrook Research Institute, and she's very interested in trauma outcomes with a particular focus on the geriatric population. And her talk will be on Ontario's trauma system, challenges and opportunities. Barbara.
Good afternoon, and thank you for letting me keep my mask on. I'm going to see my grandma for the first time in a few years tomorrow, so bear with me, okay? So I do usually study older adults, but you know, in this room, whether you work at St. Mike's or you work at Mount Sinai Hospital, you will end up seeing a trauma patient. And whether you want to at St. Mike's or you don't really want to at Mount Sinai, it's all up to how our trauma system works. That's a shout out to you, Carol. So I thought today I would talk about things that are working well in our trauma system and things that are not. Trauma surgery is fairly simple, and dare I say in this audience, it's not brain surgery. We want severely injured patients to come to a trauma center. If a severely injured patient comes to a trauma center, their chance of dying is 25% lower than if they went to another big, well-equipped hospital that isn't a trauma center. So it's simple: right patient, right hospital, right time. And we don't really want people who don't have severe injuries to be transferred. They do not benefit from places like Sunnybrook and St. Mike's. So this all started a long, long time ago, in 2010 for me. I know there's lots of residents in the audience. So this is when I was in SSTP. I was young, the world was young, laparoscopy had just been invented, the spleen hadn't been discovered yet. And David Gomez and I were sitting in a tiny office looking at how does Ontario's trauma system work. So we basically asked a very simple question. Are people getting to the right place at the right time? And we looked at all adults with a severe injury who came to an emergency department, so either an injury severity score of over 15, which is sort of a standard measure, or who died within the first 24 hours. And here's what we found. I was you 10 years ago. So we found about 20,000 patients, and almost 2/3 of them went from the scene of injury to the wrong hospital, to your Mount Sinai's, to the Toronto General, to RVH. And overall, 18% were transfer patients, and about 44% of patients ended up being admitted at non-trauma centers. So 71% of patients were never transferred, and almost half of severely injured patients in the province were not getting the right kind of care. So this is, not getting aspirin for an MI, not getting TPA for a stroke. This is on the same sort of level in terms of access to care. Then we looked at the patients who ended up dying. So in our cohort of about 20,000 patients, there were about 16% died. And of the patients that ended up dying, again, 2/3 went from the scene to the wrong hospital. 13% were transferred, and 48% of deaths happened at a non-trauma center. So in Ontario, for every patient that ended up dying in a trauma center, one died in a non-trauma center. So we asked, why is this happening? And, in a lot of places it makes sense. If you live out here, there's not a trauma center close by, and these are David Gomez's beautiful maps. So it makes sense that a lot of people can't get to a trauma center. But even in downtown areas, even in Toronto, half of the patients were going from the scene to the wrong hospital. And yet, in some places, the system seemed to work well. So what was going on? The other thing we found that was interesting was that this mistriage, this lack of access to trauma center care was not random. We found that if you were a woman in Ontario, your chance of getting trauma center care was dramatically lower than if you were a man, even adjusting for injury severity, age, mechanism. And if you're an older adult, and this is sort of where my own research program started, you were much less likely to get the right kind of care. So that was in the dark ages, right, when I was a resident. So since that time, lots has happened. Ontario now has these regional trauma networks, which, around each trauma center, there's a network of trauma centers and non-trauma centers that are working together to improve access to care. There's now actually a guideline that says, these are the criteria. If you have a patient that looks like this, you pick up the phone, you call Credit Call, a friendly local trauma surgeon or trauma team leader will take your phone call, and we're going to get the right patient to the right place. And you'll note there are patients who are considered even more vulnerable. So children, older adults, pregnant people, people who are immunosuppressed, those are people who have worse outcomes, and they should be more likely to get trauma center care. So this is the latest. What's now happened since we made all of those changes? So first, let's talk about older adults. As you can tell from my mask and from my work, I have a soft spot there. So I essentially said, okay, what's happening now, and how can I answer this question 10 years later? So again, we looked at older adults, we looked at the population level, and now I said, okay, let's add a lot more information. Let's not just look at age, but let's look at frailty, let's look at comorbidities, let's look at anticoagulation, are they nursing home, are they marginalized, what's their socioeconomic status? And I was hoping things would be dramatically different. But they were not. They're actually exactly the same where they were over 10 years ago. In fact, for older adults, things are probably worse. So if you take all older adults with severe injuries, again, these are patients who do benefit from trauma center care, 3/4 go from the scene of injury to a non-trauma center. And of those, only about 1/3 are ever transferred. So basically, access is at best 50-50. And the same predictors of having the wrong care or not having access to care have persisted. So both in the field and with secondary transfer, female sex is still an extremely strong predictor of not having access to trauma center care, and so is advanced age. But I wanted to take it a step further and look at the most vulnerable patients. And we know that frailty, basically in any field, is the single strongest predictor of outcome, whether this is in medicine, surgery, cancer care. Patients who are frail are more likely to do poorly. And yet, in Ontario, if you're frail, you're less likely to get access to a trauma center, even though your 90-day mortality is 50% higher. So we are systematically selecting patients who are likely to do poorly, and they're not getting access to care. So why is this happening? What is happening at these non-trauma centers? Clearly, in Ontario, because about 2/3 to 3/4 of patients go from the scene of injury to a non-trauma center, even in highly urban regions like Toronto, the non-trauma center plays a huge role. And they have a hard job, right? They have to minimize under triage, meaning identify all the sick people, but also minimize over triage. We really don't want them transferring people who aren't sick. So we looked at this relationship and we tried to figure out how these centers are doing it. And again, we looked at adults presenting to a non-trauma center with any injury, and we just excluded people who went home. And we defined severe injury very expansively, like if you had severe injuries by diagnoses, if you ever got blood, if you were ventilated, we assumed that it was okay to transfer you to a trauma center. And then we looked at what hospitals actually had, because one of the prevailing theories is, you know, these little hospitals, they don't have the information, must be hard for them. So, you know, highly resourced hospitals like Mississauga might do a better job than a tiny hospital that doesn't have a CT, that doesn't have a surgeon. So we basically divided hospitals based on their resources, whether they had physicians with EM training, whether they had a general surgeon, an orthopedic surgeon, a scanner, and an ICU. If you had all of these things, you were a rich center. If you had none of these things, you were a resource-limited center, and if you had some but not all, you were an intermediate center. Then we wanted to define accuracy. So this is not the easiest thing to define, right? Because you could under triage everyone and then have no over triage, or you could just send every single patient, you never miss a sick one, but you're flooding your trauma center with unnecessary transfers. So how do we define it? So it's a balance between under and over triage. And my colleague and very clever PhD student, Berg Tillman, came up with this mathematical measure, which is the diagnostic odds ratio. But it's basically the odds of appropriately transferring someone who is severely injured over the odds of over triaging someone who is not. Long story short, you want this number to be very high, okay? Here's what we found. In the non-trauma centers in the province, the accuracy, the diagnostics odds ratio, on average was 3.8, but ranged from 0.19 to 32. So a huge range of accuracy. Some centers were spot on, and some centers were almost randomly sending patients to the trauma centers. And this is adjusted for case mix. You can see there's a huge range. What was interesting is the type of resources they had absolutely no bearing on their accuracy. It didn't matter if they had a surgeon, didn't matter if they had a CT scanner, or none of those. The average accuracy was actually the same across all strata. So it wasn't the fact that they could scan and send, it was something else. We found that really under triage varied very little. So it was consistently actually very bad. So under triage ranged from 80% to 68%, but over triage had a huge spread. The probability of patients just sending patients with very minimal injuries went from 4 to 31%. And after we adjusted for differences in case mix, we actually found that across the province, basically, centers were missing the same amount of severely injured patients, essentially older women who had fallen. But the probability of sending a younger male patient who had no significant injuries varied widely across centers. And when you adjusted for everything else, there was more than a 3-fold variation in the likelihood of over-triage between centers, meaning it wasn't whether they had a scanner, it wasn't whether they had an ICU, there was something in their culture that was causing them to send patients out who did not require transfer, flooding places like Sunnybrook and St. Mike's, with actually no improvement in identifying those who could actually benefit. Huge costs, no patient benefit. So what do these data show us? So despite the fact that in the literature, the argument is always, well, if you fix under triage, if you send all these older adults, you're gonna flood hospitals. Over triage and under triage seem to be quite unrelated. You can have high and low over triage rates and you basically keep back the same proportion of patients. The hospital of presentation, the culture of the hospital to which you are brought, is the single greatest driver of whether you're going to be transferred or not. It's really got nothing to do with your injuries. And whether you have resources or not also plays a minimal role. So what does that tell us? We need to figure out how to get this right. You know, clearly people who could benefit aren't coming to us. We are getting a lot of patients where there's no benefit from an injury perspective, and obviously a lot of stress on the system, on our resources, and also on the patient. And we need to figure out what's happening at these high and low performing centers, because it's not about what they own or what kind of people they have. We really need to get the perspective of ED physicians. So yesterday I talked at Canada's largest EM conference, because those are people we don't really interface with, right? Community EM physicians, what are they thinking, what are they doing, and why are they sending us the people that they do? And it's got a lot to do with our attitudes and the perceived pushback that they get when they try to send us older adults who don't need surgery. And I think these are critical perspectives that we're really missing out on. And lastly, there's opportunities to compare to how other provinces do this. You know, now we have some level 3s in Ontario, but other provinces like BC and Quebec are much more inclusive, and there are options between small community hospital and huge downtown hospital. Are they doing this better? And with that, I'd like to thank my lab and my mentor, Avery Nathans, and take any questions.
Thank you, Barbara. And I think this talk kind of shows the application of trauma to a systems level and to the community level. Any questions? Okay.
Thank you. That was really enjoyable. I'm just wondering about when something gets defined as a trauma and how, because just from observation, one element is the recognition that it was a fall, and that can be delayed. So for this database, when is that moment that it gets defined? And maybe you end up in the wrong hospital and you've been there for 4 days before it's recognized. What happened?
That is actually a fantastic question, and it's actually a whole program of research done by some colleagues in the United States. The fact of the matter is, if an older adult falls down those stairs, most doctors don't think that that's a trauma. But those of us who see these patients all the time, and especially my colleagues in neurosurgery, know that life-threatening injuries can happen. So the error starts right there at the beginning, and it's more about heuristics than about guidelines. So the guidelines clearly say a same level fall with severe injuries is a trauma, but doctors and paramedics, we don't follow guidelines, right? We follow our gut. And a trauma patient, our gut tells us, is a 20-year-old man who's been shot and not a 70-year-old woman who's fallen. And so I think it unfortunately starts with sort of education and sort of changing the way that we teach this, because guidelines already exist and haven't really changed what we do. But certainly a same level fall with severe injuries is a trauma.
Yeah, it's just comment. Also, I think it's what Carol Swallows brought up is a great comment. So one of the most common errors that I actually see from a spine surgical perspective is missing what now epidemiologically in North America is the most common type of spinal cord injury, which is what's called a central cord injury in the absence of a fracture. And people do not recognize that people have actually had a spinal cord injury. It's a critical error, big source of medical legal as well, big error. So a question to Professor Hutchison.
Yeah, that was a great talk, really interesting. Thank you. This issue of the gender discrepancy, that's just whether you had any more thoughts about that, and does it apply both to direct transfer to major trauma centres and as secondary transfer? Is it both those categories? And why is this happening, do you think?
I think it's implicit bias. I don't think anyone's out there being like, you get back to your kitchen, no trauma center for you, but it's common in invasive procedures and invasive interventions across fields, right?
Sure.
Like ICU surgery. So, you know, when Dr. Gomez, when David, who's the first author, wanted to publish this, the feedback we got was like, this is awful, how dare you say this, but it's seen across the literature. So I think it's the idea, you know, she probably wants to stay close to her family, or like it's not overt, but.
So it's even within the ambulance at that first decision point?
100%,
Yeah,
100%.
yeah, thank you.
Great, thank you. So Barbara, don't go away. We're calling upon you to switch roles now as our chair for our...
I have to get my papers. I'll be right back.
Go get your papers. So everybody maybe take a 2-minute stretch break. And then, so we're going to transition now to phase 2 of our e-poster presentations, and then that will be followed up by the Gallie, Bateman, McMurrick, and translational research presentations. And Dr. Haas will be transitioning from able speaker to chairperson.
All right, friends, that was your stretch. I'm going to ask you all to come and welcome me in join me in welcoming our e-poster presenters. So I'm delighted to present our first presenter, and this is going to be Andrea Ovchak, who will be presenting her e-poster on titled Dantrolene Reduces Hypoxic Ischemic Brain Injury in Mouse Model.
Hello, my name is Andy, and I'm a PhD student in Dr. Zong Ping Feng's lab in the Department of Physiology. I'm very grateful for the opportunity to be here today to share with you our recent work, which pertains to the neuroprotective effects of dantrolene in treating hypoxic ischemic brain injury in a neonatal mouse model. So to begin with a bit of background, hypoxic ischemic or HI brain injury and resulting encephalopathy represents the most significant cause of neonatal mortality and morbidity globally. It may be caused by any event during the perinatal period that causes hypoxemia and/or obstructed blood flow. Therapeutic hypothermia is the current standard of care, yet the rate of death and neurological sequelae ranging from mild cognitive deficits to more severe permanent impairments such as cerebral palsy remain high. This highlights the pressing need to identify key molecules contributing to HI pathology such that novel and targeted therapeutics can be developed. So thus far, previous literature has suggested that the progression of HI occurs in distinct temporal events, beginning with the primary depletion of high-energy phosphates, which leads to this elevation of intracellular calcium. Following a transient recovery period due to blood reperfusion, there is then this secondary surge of calcium-mediated excitotoxicity, which is a salient mechanism in then mediating injurious downstream cascades, such as induction of the ER stress response, ROS production, or oxidative stress, all of which ultimately lead to this irreversible neuronal death. And so we have decided to focus our attention on this dysregulation of calcium homeostasis, this sort of hub of injury responses, which is mediated by three main sources under HI conditions, including excessive extracellular influx, inhibited extrusion mechanisms, and increased intracellular release, the latter of which implicates the ryanodine receptor. Now, ryanodine receptors facilitate the mobilization of calcium from ER luminal reserves. They represent the main source of intracellular calcium signaling, and the three isoforms undergo dynamic expressional changes during that perinatal period. Ryanodine receptors are thus implicated in that ionic imbalance that is characteristic of HI. So we have dantrolene, which is an FDA-approved ryanodine receptor antagonist, and it's used clinically in the treatment of malignant hyperthermia. Dantrolene thus represents this tool that we can use in order to better understand the contributions of the ryanodine receptor. Thus, the objectives of our study were to investigate the role of the ryanodine receptor in HI-induced injury in the developing brain and evaluate the potential neuroprotective effects exerted by dantrolene. So the methods that we employed in order to address these objectives included the in vivo Rice-Finucci HI brain injury model in postnatal day 7 mouse pups. In brief, dantrolene at 5 milligrams per kilogram or equal volume of vehicle solution were administered intraperitoneally 30 minutes prior to the induction of HI. To induce ischemia, the right common carotid artery was isolated and ligated. And then following a 90-minute recovery period with their mother, pups were placed in an airtight hypoxic chamber perfused with a 92.5% nitrogen, 7.5% oxygen mixture. Morphology, neurobehavior, and molecular signaling were then assessed at various postnatal time points outlined here. In terms of our in vitro work, primary cortical neurons were cultured, and on day 3, either 90-minute oxygen glucose deprivation, or OGD, or calcium imaging were carried out. So moving into our results, TTC staining, which is a redox indicator that distinguishes between metabolically active and inactive tissue, was carried out 24 hours post-HI and revealed that dantrolene reduced infarction volume in the ipsilateral hemisphere to approximately 20% compared to 54% as was seen in the vehicle-treated group. This reduction was still evident at 7 days post-HI when initial staining was carried out, seen in B, and at 25 days post-HI after liquefactive necrosis was evident, seen in C. We next evaluated the effect of dantrolene on functional recovery, and a sham dantrolene control group was included in these assessments. Dantrolene is a muscle relaxant due to its inhibitory action on skeletal muscle EC coupling, and so we wanted to ensure that its usage at this postnatal time point did not impact proper behavioral development. So short-term outcome was first assessed using the leading evaluations of rodent reflex development outlined in the schematics shown here. Importantly, outcomes in sham and sham dantrolene mice were comparable and no adverse effects were associated with the treatment. Moreover, while neurobehavioral deficits were observed in the HI vehicle mice in all of the tests, the dantrolene-treated HI mice exhibited improved performance, particularly on the negative geotaxis reflex test, cliff avoidance, and grip tests. In addition to improving short-term functional recovery, dantrolene was found to improve long-term functional recovery based on assessments carried out from postnatal days 28 to 32, and this was 1 week after mice had been weaned and gained nutritional independence. So specifically, dantrolene-treated HI mice were found to have preserved balance and motor coordination as indicated by an increased latency to fall on the accelerating rotarod task. As well, dantrolene HI mice had preserved learning and memory capacity as indicated by the one trial passive avoidance task in which a mouse learns to refrain from crossing from a light to dark compartment in which a foot shock was previously administered. And finally, pup body weight was measured throughout the course of neurobehavioral testing, and we observed that dantrolene-treated mice exhibited a trend for increased body weight compared to the vehicle-treated mice. Then, in order to investigate the molecular mechanisms underlying dantrolene-mediated neuronal protection, Western blot was carried out 24 hours post-HI in the ipsilateral penumbra. And in accordance with previous reports, we found that HI was associated with increased protein expression levels of the pro-apoptotic cleaved caspase 3 and 9, as well as a reduction in the pro-survival molecule protein kinase C. Additionally, glycogen synthase kinase 3 beta in its activated form and hypoxia-inducible factor 1 alpha, which have also been shown to be involved in pro-apoptotic signaling, were found to be upregulated. And incredibly, dantrolene is actually found to mitigate all of these effects, as you can see in the white bars here. Furthermore, these effects or giving us neuronal protection were sustained 3 days post-HI, as indicated by reduced tunnel-positive cells, which is an indicator of DNA fragmentation. And so together, our Western blot and tunnel staining findings suggest that dantrolene inhibits apoptosis and promotes pro-survival signaling in the developing brain. Moving on, we next evaluated the effect of dantrolene against cortical neurons subjected to anoxic insult in vitro using the OGD paradigm, after which point cells were then returned to regular glucose-containing medium, either with dantrolene or vehicle solution. So as shown in A, the developmental stage of neurons did not differ between our control, OGD vehicle, and OGD dantrolene groups, but as shown in B, dantrolene did in fact protect against OGD-induced injury, as indicated by a reduced PI fluorescence intensity at both 1 and 13 hours post-OGD. And then finally, Fura-2 calcium imaging was carried out in order to validate the ability of dantrolene to inhibit calcium release. And so in order to test this, caffeine, which is a known ryanodine receptor agonist, was applied either in the absence or presence of dantrolene, and we found that dantrolene reduced the caffeine-induced calcium signaling by approximately 39.8%. So this finding in particular highlights the role of the ryanodine receptor in neuronal calcium homeostasis and suggests that dantrolene may afford neuroprotection by inhibiting cytotoxic calcium levels. And so this is just a summary schematic of our findings from this proof of principle study, which suggests that ryanodine receptors may in fact contribute to that ionic imbalance and are a critical target. Outlined here are also some of the key signaling molecules we have identified thus far, which implicate multiple signaling pathways that dantrolene actually may be acting on. In terms of the clinical implications, dantrolene at 5 milligrams per kilogram actually falls within that administration range used in pediatric populations for the treatment of malignant hyperthermia. And so the clinical availability and selection dose of dantrolene really highlight the translational relevance of our findings, particularly regarding the use of dantrolene as a prophylactic, because we did administer it in a pretreatment paradigm. Accordingly, the next steps that we're taking in our lab are to, 1, determine the therapeutic potential of dantrolene and whether it is still effective when administered post-injury. 2, evaluate the potential of dantrolene as an adjunct to hypothermia, which is the current standard of care. And 3, evaluate the role of the individual ryanodine receptor isoforms, as they do exhibit distinct spatiotemporal expression profiles. And that takes me to the conclusion of the presentation. Thank you very much to our collaborators and funding. And again, thank you very much for this opportunity.
I'd like to invite Dr. Muir-Lipsman to discuss this beautifully presented work.
Thanks very much. I don't know if you can hear me. I don't know if it's on. Is it? Yeah, it is. Perfect. Really, really well done. It's a lot of work. So really elegantly done, which I understand you published already, so congratulations. Just a quick question about dantrolene itself. So I'm aware that it's under investigation for Alzheimer's disease, really, and other neurodegenerative conditions. Based on your work, do you think, when do you think that this drug would be most effective in sort of those kind of indolent, slowly progressive neurodegenerative conditions, or more acute injury to the brain? When do you think dantrolene would be most effective?
Thank you for your question. Yes, dantrolene has been quite extensively studied, as well as other kind of ryanodine receptor blockers and different mutations in the ryanodine receptor, particularly in the context of Alzheimer's disease. In terms of when it would be most effective, in our case, calcium-mediated excitotoxicity plays a major role in that secondary phase of injury progression. So the therapeutic window for HI is essentially within 6 hours, because after 6 hours, that secondary energy failure ensues and the calcium levels are very high. So we want to apply dantrolene ideally before that 6-hour window, before the calcium-mediated excitotoxicity becomes too extensive. So I would assume or presume that this would apply to other neurodegenerative diseases as well, before the calcium dysregulation becomes too extensive, that those downstream molecular cascades are already ongoing and leading to that irreversible death.
Thank you.
Thank you.
I think you're going to have one more question.
Thank you.
Well presented, congratulations. Were you surprised that you only had a 39% reduction in the calcium level? And do you think by using a higher dose, maybe up to 10, that you might get a little bit more reduction, or maybe combining different types of drugs with different mechanisms?
Yes, absolutely. We didn't run like a dose response curve, so it could definitely be possible that a higher concentration would reduce that calcium signaling to a greater extent. Additionally, though, caffeine, which we use as our agonist, also has other targets, so that could also be contributing to the rise in intracellular calcium that we observed. Okay, thank you so much.
That was great. I'm happy to now invite the first prize winner in translational research, Miguel Alfonso Principe. Hopefully I got that right. He will be presenting detection of satellite tumor cells in peritumoral edema and infiltrative soft tissue sarcomas using targeted gene sequencing. Welcome.
Hi everyone. I just go by Miguel if you'd like. It's okay too. I got 2 first names. But good afternoon. Today I'm a first-year master's student under Dr. Kim Choi, a surgeon in this department, and I'll be presenting my project, Detection of Satellite Tumor Cells in Peritumoral Edema and Infiltrative Soft Tissue Sarcomas using targeted gene sequencing. That's a lot of words, so let's get started with the basics. What are soft tissue sarcomas? Well, they're a rare heterogeneous group. I forgot to take my mask off. They're a rare heterogeneous group of cancers arising from mesenchymal origins, which are essentially connective tissues. The standard of treatment is limb-sparing resection, typically added with neoadjuvant radiotherapy, or RT. One remaining issue to this day is local recurrence, and one contributing factor to this local recurrence is positive treatment margins. So this is further complicated by the presence of infiltrative soft tissue sarcoma subtypes, namely undifferentiated pleomorphic sarcoma, or UPS, and myxofibrosarcoma, or MFS, which still recur at the negative margin. These also happen to be the most common soft tissue sarcoma subtypes out there, and they have a tendency to infiltrate along or within the facial plane. There was actually a study done by the Iwata group that found that in UPS and MFS cases, you can find suspected infiltrative growth via MRI in 24% of these cases. So how do they see this suspected infiltrative growth in MRI? Well, in preoperative T2-weighted MRI, you can see this sort of tail sign. So it's a positive signal that looks like a tail. And it's unclear if this region of peritumoral edema is only reactive or if it contains satellite tumor cells. So our question is, how do we lower local recurrence rates without compromising the quality of life for patients? Well, to do so, we need to know on a patient-specific basis where exactly localized treatment should be done. Should we only do the tumor, or should we include the peritumoral edema surrounding it? To determine the extent of malignancy is no easy task. Even with trained experts, it's still difficult to differentiate between tumor and normal cells on using current histological and radiological techniques. Thus, we asked ourselves, why not do it on a molecular basis? So our hypothesis is that targeted gene sequencing can be used as a diagnostic tool for satellite tumor cells detection in the peritumoral edema of infiltrative STS. So what exactly is targeted gene sequencing, or TNGS? Well, essentially it differentiates between tumor and normal cells using tumor-specific nucleotide variants, or TSVs. Our group recently ran a successful pilot study of STS patients to detect circulating tumor DNA, which is similar in that it's low abundance, and we want to translate it to satellite tumor cell detection. So how does general TNGS workflow work? Or how is the general TNGS workflow in sarcomas? Well, first you have to run whole exome sequencing on a patient-specific basis because sarcomas are genomically very heterogeneous, and we do this between tumor and patient-matched blood. From the whole exome sequencing data, we select 3 to 5 tumor-specific variants per case, and the criteria is high tumor allele frequency, a high read depth, and its uniqueness within the human genome. After this, we use the digital droplet PCR platform to assay the peritumoral edema for these TSVs. Our controls are the tumor as a positive control and normal as a negative control for these TSVs. So to determine if targeted gene sequencing can detect satellite tumor cells, we ran a, so ddPCR should give a 2-variable plot with 3 distinct populations. First is a no DNA droplet, which is a population was expected in all conditions. Second is a TSV positive droplet, which is expected in tumor, as well as peritumoral edema, only if there are satellite tumor cells present. And lastly, a wild type allele positive droplet population in all conditions that have DNA. So to determine if TNGS can detect satellite tumor cells, we ran a retrospective cohort of 8 cases from our sarcoma biobank at Mount Sinai. The criteria was that they were re-reviewed as UPS or MFS, since they're the 2 subtypes known to be infiltrative, the tail sign, which is radiological evidence of of infiltrative growth, and that they have atypical spindle cells, which is the histological suspicion that there are satellite tumor cells. So our results showed that we can detect TSVs from whole exome sequencing data within ddPCR in the peritumoral edema. And I'm just going to walk you through this figure that there is, because there's a lot going on. So in this case specifically, it's a UPS overlying the knee, which was resected without neoadjuvant radiotherapy. We selected 3 TSVs, but highlighted here is one specific non-synonymous TSV of Col16A1, which we saw in our whole exome sequencing. So from the top left is an axial preoperative T2-weighted MRI showing the tumor mass and that hallmark tail sign again. And on the right is the peritumoral edema. First is the H&E stain, which shows that there are atypical spindle cells, but we're not sure if they're satellite tumor cells or if they're only reactive edema. But in the ddPCR plot accompanying it beside it, it shows that there's a clear TSV positive droplet population, indicating that that H&E stain is showing satellite tumor cells. As for our controls, we can see that in the tumor, we can see viable tumor in the H&E stain, while the ddPCR plot is confirming this with a strong TSV positive droplet population, while our normal control is showing fat in the H&E stain, while the ddPCR plot is showing an absence of these TSV positive droplets. So so overall, our retrospective from our retrospective cohort, we saw that we could extract DNA from the peritoneal edema in 6 cases. And of these 6 cases, we can detect one TSV positive droplet population in the peritoneal edema in 4 cases. So with such promising results, we decided to run an ongoing study of 8. So we selected 8 cases with the tail sign in preoperative MRI who were prospectively selected, and each underwent up to 3 methods to diagnose satellite tumor cells in a parallel blinded fashion. So these 3 methods is firstly standard histology, which was done by our amazing pathologist, Dr. Brendan Dixon, targeted gene sequencing, which was done by the research team, which is me, I guess, which is me. And in select cases, it was diffusion-weighted MRI, which is done in conjunction with our musculoskeletal radiology team, spearheaded by Dr. Lawrence White. We hope in the future that we can compare these observations from each technique But in the meantime, we've also decided to apply lessons we learned from the retrospective in what we collect for our prospective. So the first part is that we decided to collect a distant normal site, and this helped us get a complete absence of any positives in our negative control, which, as you can see here, in this case, I'm showing the fractional abundance, which is a statistic of how much positive tumor positive droplets there are, and in normal, it's completely 0%. But most importantly, we decided to collect all planes of peritomal edema that were deemed clinically relevant by the practicing surgeon. In this specific case that I've highlighted here, which is showing TSV of ATRX, we can see that in all conditions but the anterior, there are satellite tumor cells present. And just to bring the point home, I've selected two specific ones. On the left, you can see posterior superior is showing a slight droplet population with a variant allele fraction of 0.21, whereas anterior is completely absent of any of these droplets. As stated, this is an ongoing study, so other future directions is we plan to compare the FFPE tissue quality with fresh frozen. And other avenues that we'd like to explore is the potential role that neoadjuvant radiotherapy has in impeding our platform, because it might be introducing DNA damage into the platform, thus making it difficult to interpret. And lastly, on a more broader scale, we want to explore if epigenetic markers, specifically DNA methylation changes, can be used as an alternative marker for targeted gene sequencing. So overall, the anticipated impact of this study is to improve treatment for local STS through inclusion of satellite tumor cells on a patient-specific basis. So ultimately, we want to, the anticipated impact of this study is to, we hope to achieve local control for all cases while maintaining the quality of life for patients. Thanks for listening, and I'd like to acknowledge the Andrulis Wonder Choi Lab, our grad students, our radiologists, and everyone included. Thanks.
I really enjoyed that. That was fantastic. I'd like to invite Dr. Andrea Covelli to be our discussant for this great presentation.
Interesting talk. Thanks for sharing, Miguel. Many of the questions I had prepared, you've actually started to address in your prospective studies, but I guess two questions. I believe one of the slides you mentioned.
Sorry, Dr. Covelli, I can't hear from my end. You're gonna have to speak into the mic a little bit closer, okay. Sorry.
One of my questions was you said in one of your slides you only managed to extract on 6 of 8 of your specimens. Mm-hmm. Could you talk about some of the limitations of that? And my second question, you've addressed a little bit, was around neoadjuvant radiation, which we know we use quite frequently in extremity sarcoma. Mm-hmm. You did have some neoadjuvant samples included in your retrospective study. And were you able to successfully analyze those samples, or was that a limitation in your retrospective?
Those are two great questions, and they're actually connected to each other. So firstly, it's correct that in our retrospective study, there were 2 cases that we couldn't detect, that we couldn't extract sufficient DNA for ddPCR detection, and 2 of them happened to be happened to have been treated with neoadjuvant radiotherapy. The other confounding issue that we had, and that's why we also included as a future direction, is to compare archival FFPE with fresh frozen, is that we're not sure if this insufficient DNA is arising from the fact that we used archival FFPE, because not mentioned is this retrospective cohort where patients collected from 2008 to 2018, so it might have been just either the media or the age of what we collected, or if it's the fact that it's neoadjuvant radiotherapy. We're not too sure because, again, our cohort size is only proof of principle, so we only have about 16 cases in total, and there's only 4 of them that are radiotherapy, that we've been treated with radiotherapy, but there is some suspicion that because, especially for the retrospective, as shown, all 4 cases were either insufficient DNA or negative for these satellite tumor cells. And for a retrospective cohort, we specifically chose cases that we suspected would test positive, like we selected the most likely. So we're not too sure whether it's the FFP, if it's the media that we've extracted DNA from, or if it's neoadjuvant radiotherapy. And those are very good points, and I think they're perfectly valid future directions. Thanks.
Thank you. And having said that, as you move forward with your prospective study, you talked about the tails of the MRI, which we frequently see. Will you be trying to sample on the tails pre and post neoadjuvant, or how are you going to assess that neoadjuvant effect on the applicability?
So at this point, I believe that at Mount Sinai, it's only the standard for some subtypes is that they're treated completely with no neoadjuvant therapy. So I believe in that sense that might be a little bit out of my scope, especially. So, but there is a hope to compare between cases that aren't treated with neoadjuvant radiotherapy and cases that are treated with neoadjuvant therapy, but not on like a patient-specific basis, but more on a cohort-specific basis, if that, yeah.
Thank you.
Thanks.
Fantastic. I don't know if I should give up on that microphone or not. I'm very pleased to now invite the first prize winner from the SSTP stream. It's Dr. Justin Wang, who will be presenting his poster titled Predicting Response to Radiotherapy in Meningiomas Using DNA Methylation Signatures and an Applied Machine Learning Approach.
Let's go forward. Thanks very much, Dr. Haas. My name is Justin. I'm one of the PGY4 neurosurgery residents. It's a great honor to present here today, so thanks for the opportunity. I'm presenting on one of our projects and looking at response to radiotherapy in meningiomas. My supervisor is Dr. GallieDay. So meningiomas are the most common brain tumor in adults. They make up about 1/3 of all brain tumors and over 50% of all benign brain tumors. So far, the contemporary grading for meningioma still largely relies on histopathology, with higher WHO grades conferring worse clinical behavior. The standard of care for meningiomas is, the first line is maximal surgical resection for symptomatic tumors, and then hopefully, with that alone, patients are cured. But there are a subset of meningiomas that are clinically aggressive. And for these tumors, which may be higher WHO grade, which may have an incomplete resection, they may get radiotherapy, and sometimes this may lead to a cure. But in other cases, if they recur after radiation, there really aren't any additional therapies that are available for these tumors. So patients are stuck in sort of this holding pattern of repeat surgery, repeat irradiation. And so these radiation-resistant meningiomas really are responsible for the majority of the morbidity and mortality associated with these tumors. And the guidelines for the treatment of these tumors still relies on WHO grade in determining which of these tumors should get radiation. But what if you have two WHO grade 2 meningiomas that are essentially the same histopathologically? Both have a very good resection, and then both start to recur. The top tumor you can see sort of at the temporal pole, you see some recurrence starting to happen. The bottom one is a bit more obvious. And so both these tumors get radiotherapy once they recur. The bottom tumor remains stable, there's no change, but the above tumor continues to recur, requiring another operation. And the advances over the last few years has been many papers looking at the molecular alterations in meningiomas, and there's been a lot of advances on the alterations, including DNA methylation, that are able to better predict the biological behavior of these tumors compared to just WHO grade and histopathology alone. But the limitation of these papers, however, is that while they have uncovered some novel therapeutic vulnerabilities, a lot of these drugs are still in the preclinical stages, and there's been sort of no studies on which tumors are radiation responsive or biomarkers of radiation responsiveness in these tumors. And certainly clinically, there's some equivocal evidence as well as to, how well radiation works for these tumors, particularly for WHO grade 2 tumors, which are highly heterogeneous, and recurrent WHO grade 1 tumors. And so you've got a number of different clinical trials, 2 phase 3 trials that are ongoing, and 1 recently completed phase 2 trial, looking at exactly which patients will benefit from radiation. So to start off, we wanted to basically look at a large consecutive cohort of patients treated with fractionated radiotherapy. Most of the current studies are limited to a single institution, or they've compared radiation versus no radiation, and that usually has inherent selection bias if you're looking at it from a retrospective standpoint. So we looked at 404 tumors that were all treated with radiotherapy from 4 different centers. And as you sort of expect, the survival curves, you can see that just like progression-free survival after surgery, progression-free survival after radiation gets worse with increasing WHO grade. In the lollipop graph there, you can see that in the blue, the majority of the recurrences actually occur within 5 years of radiotherapy. So around 80% of these tumors, if they recur after radiation, do so within 5 years. And if you look at the survival curves, about 50% of grade 2 meningiomas will still recur despite radiotherapy, and 75% of WHO grade 3 meningiomas will still recur in spite of radiotherapy as well. So clearly we need a more granular way of breaking down which of these tumors within each grade will respond to radiotherapy or won't. When we did a univariate and multivariate analysis, by feeding a Cox regression model with these clinical covariates, we found that the only clinical factors that independently predicted worse progression-free survival after radiotherapy was having a WHO grade 3 meningioma, which comprises less than 1% of all meningiomas clinically, older age of diagnosis, and then having had previous radiotherapy to that meningioma, which again only comprised about 5% of patients in this cohort. And when you break it down by WHO grade, really the only consistent thing that predicts poor progression-free survival after radiation is having had previous radiation to that tumor that's failed. So again, we need a more sort of granular way of predicting which of these tumors will recur after radiation and which won't. So we performed DNA methylation on 165 of these meningiomas using the Illumina 850K EPIC array. And we did this because DNA methylation has been shown to be highly prognostic for meningiomas. When we did consensus clustering, which is agnostic to outcome, just based on the differentially methylated regions of these tumors, we found 2 stable clusters, and we'll just call them cluster 1 and cluster 2. And you can see that cluster 2 meningiomas in the blue did far poorer after radiotherapy. Basically, they comprise the majority of radiation-resistant meningiomas. And even within each WHO grade, this relationship still holds true. You see, within WHO grade 1 and grade 2 meningiomas, the cluster 2 meningiomas perform far worse. The WHO grade 3 tumors, the relationship was not significant, partially because I think these tumors just recur quite quickly and because of lower sample sizes, I suppose, in this group as well. When you fit multivariate Cox regression with this cohort of tumors, you can see that really the methylation cluster is the only thing that's really predictive of outcome. So we know this, so how do we then translate this to something clinical that we can use for our patients? And we did this by drawing upon our previous experience. My colleague Farshad wrote this paper on using DNA methylation to develop a recurrence model after surgery for these meningiomas. We basically looked at the 850K CPG probes, and we basically picked the probes that were associated with progression-free survival on a univariate analysis. And in order to differentiate this from the model of surgical recurrence, we compared the probes that we used for our model building to the previous one, and we found that, you can see in the green here, the majority of the probes that we found that were associated with progression after radiotherapy were independent of those that were predictive of recurrence after surgery. And so we performed modeling using gradient boost modeling. I won't sort of go over the details too much, but essentially it's a type of machine learning modeling that builds a series of sequential decision trees. And after sort of each decision tree, you have these residuals or these errors, which is the difference between the predicted and observed outcome. And then it feeds it back into the building of the next tree, and then until basically you minimize the amount of error or you pre-specify the number of trees. And so we built an XGBoost model, which is sort of a variation of the gradient boosted model, to be able to predict which of these tumors will recur after radiotherapy. And we found that when we plotted the ROC curve and the area under the curve, the AUC for our XGBoost model was 0.832. which was significantly better than a model that just used WHO grade alone. And we did this by first splitting our cohort into a 60-40 training testing cohort, and the test cohort we didn't use to train the model. When we compare this to our previous surgical recurrence model, we found that the radiation model the new radiation model also performed better than the surgical recurrence model. And in fact, when we built different models using different techniques, XGBoost that I showed earlier, random forest, or the previous boosted regression model, they all outperformed WHO grade, and they all outperformed our previous predictor as well. And we validated this on some small external validation cohorts, and they similarly showed quite good performance. And we're adding to these validation cohorts as well for the time being. And the goal is then to incorporate this methylation-based predictor along with the clinical covariates that can predict progression-free survival after radiotherapy, and then developing a nomogram that can then predict for each individual patient what their risk of recurrence is over a period of time after they receive radiotherapy. And so some future steps are, so we have that tool now that we can hopefully implement clinically, but biologically, how do we uncover the biological mechanisms of radiation resistance? And we can use some of the data we have from the DNA methylation. So overall, of the significant probes that we found, we can break them down into probes that were unfavorable or favorable. There were far more unfavorable probes. And then we can map these to protein coding genes. And then we can correlate this with transcriptomic data from our RNA sequencing of these meningiomas. And basically, we can see here that just based on the transcriptomic data alone, these meningiomas will segregate into their methylation-based clusters roughly. And then you can see that there's the graph on the side, the volcano plot shows the differential sequencing analysis comparing the radiation-resistant versus the radiation-sensitive meningiomas, which shows some notable gene markers that can be used for subsequent functional studies and biological studies. And then we've also been able to preliminarily uncover that these methylation markers that you see in the tissue of these tumors can also be found in the plasma of these patients. And this is important because if we can detect the radiation responsiveness of a meningioma just based on a patient's plasma, this can help with surgical planning for patients that have radiation-sensitive tumors. You might plan a subtotal resection with adjuvant radiotherapy. And for patients with radiation-resistant tumors, you might undergo a more aggressive operation to try and remove it all. So those are the subsequent steps. Thank you very much to everyone who helped, particularly Dr. Zadeh, of course, our very talented bioinformatician, Dr. Vikas Patel, who helped with analysis, and Farshad, whose work this builds off of, and our funding agencies, and of course the SSTP program.
Amazing work. I'll invite Dr. Deo Podolsky to be our discussant.
Thank you. Can you hear me?
Yep.
So congratulations. That's a ton of work and really, really fantastic. So I'm a plastic surgeon. I don't have a lot of experience with this, but I have a few questions. So you alluded to this in your talk, but why is the difference in the radiosensitivity preserved for the WHO grade 1 and 2 tumors and not the grade 3 tumors?
Yeah, it's a very good question. I think it has to do with a couple of things. So it may be that all WHO grade 3 meningiomas are just radiation resistant, or the majority of them are. And that may be the group that we need alternative targeted therapies for. That may be the group that just radiation won't work for. It may be that they're just, as a group, they're recurring far too quickly for us to show a difference between the radiation responsive and radiation resistant groups after radiotherapy. And also they're quite rare, so they make up about less than 1% of all meningiomas, and about like 5 to 10% of all irradiated meningiomas. So our sample size remains quite small. So if we had a larger cohort, perhaps we would see some differences that would be borne out.
Great. And my final question is, you presented on your nomogram for prediction of recurrence. Do you think you have enough data to suggest that if you had a patient with a grade 3 tumor and you've determined that it's radio resistant, would you not offer radiotherapy given your findings at this point?
Yeah, I mean, the predictor, I think, still needs some work and obviously needs prospective validation before it can become sort of, like a standard of care type thing. But I think it can be used as a very useful adjunct for patient counseling. You can tell them that, look, this is what the data shows, and it gives them additional information on top of just telling them this is a grade 3 tumor, you're going to have a bad outcome. And then you can make the decision, because I think on the whole, we are probably over-radiating these tumors. Radiation is not innocuous, intracranial radiation, particularly for elderly patients. They develop cognitive decline. Depending on the location, they get hydrocephalus and require shunts. And so, I think it'll be important for counseling in the sort of the immediate future, but sort of moving forward, perhaps it can be more than that.
Great, thank you.
Thanks.
And now for the last talk in this session, the first prize McMurray winner, Katarzyna Pieczonska, who will be presenting her poster, Transplantation of Human Oligodendrogenic Neuroprogenital Cells for the Treatment of Cervical Spinal Cord Injury. Congratulations.
Thank you. Thank you for that introduction, and thank you to the organizers of GallieDay for having me here today. So my name is Kasia, and I am a PhD student in Dr. Michael Fahling's laboratory, and today I will be presenting some of the work that has been done in our laboratory, titled Transplantation of Human Oligodendrogenic Neural Progenitor Cells for the Treatment of Cervical Spinal Cord Injury. So just to give some background, spinal cord injury leads to severe sensory motor impairments which reduce quality of life. And although there are some treatment interventions that exist, such as surgical interventions or pharmacological interventions, currently there is no cure. Now, from a pathophysiological perspective, demyelination is one of the main hallmarks of SCI, and it ultimately contributes to impairments in neural signaling within the spinal cord. So with that in mind, one of the regenerative or therapeutic approaches for SCI is to transplant neural progenitor cells, which are these tripotent cells that can give rise to oligodendrocytes, which are the myelinating cells of the central nervous system, as well as astrocytes and neurons. However, what our lab and others have been finding is that following transplantation of these NPCs, what happens is that they tend to differentiate into scar-forming astrocytes at the expense of both neurons and oligodendrocytes. And so these efforts have been a little bit counterproductive. And so with that in mind, the purpose of our work was to first of all generate human oligodendrogenic neural progenitor cells, or ONPCs for short, which would be biased to differentiate into a greater proportion of oligodendrocytes while still giving rise to both neurons and astrocytes, and to characterize them in vitro. And we furthermore also aim to assess their regenerative role in vivo in a clinically relevant model of cervical spinal cord injury. And we chose to do this in cervical spinal cord injury, given that it is the most prevalent in the human patient population. So that brings me to our experimental outline for the in vitro work. So briefly, fluorescently tagged human NPCs were treated with several small molecules in vitro, and these ONPCs were then characterized using qPCR in vitro. So qPCR was used to assess their identity, and we furthermore assessed the differentiation profile of the cells using immunocytochemistry. So here we have the in vitro results. On the left-hand side, we have the results from the immunostaining. So at the top, on the left-hand side, you can see the TUJ1 staining, which is a neuronal marker. In the middle, we have GFAP staining, which is an astrocyte marker. And then below that, we have O4, which is an oligodendrocyte marker. And then when we quantified these stains, we found that the ONPCs were in fact biased towards differentiating into a greater proportion of oligodendrocytes in vitro. And furthermore, when we performed the qPCR, what we found was that several oligodendroglial lineage markers, such as OLIG1, OLIG2, SOX10, and so on, were upregulated in the ONPCs in comparison to unbiased NPCs that were not treated with these small molecules. And so moving forward, we aim to test the regenerative role of these cells in vivo. And so we had rats, and we subjected them to a cervical spinal cord injury. So briefly, what we did was we used a clip compression injury in which a small clip is placed along the spinal cord and it is released and closed along the spinal cord in order to compress it. And then following 2 weeks, we transplanted the rats with either ONPCs or vehicle. And then 8 weeks following that, we ultimately sacrificed the rats and performed histological assessments. And importantly, we also performed weekly neurobehavioral assessments over the course of the study. So moving on to the results. So on the left-hand side here, we have an image of the spinal cord transection, which shows the GFP-positive transplanted cells. And then on the right-hand side, we have the differentiation profile, the quantified differentiation profile of the cells. So we aim to assess what they were differentiating into in vivo. So we stained for APC and OLIG2, which are oligodendroglial lineage markers, GFAP, which is again an astrocyte marker, and then NUN and TUJ1, which are neuronal markers. And again, we found that the ONPCs, similar to the in vitro results, were also found to be biased along the oligodendroglial lineage in vivo. Now, we next aim to determine whether these ONPCs were actually capable of producing myelin and promoting remyelination. And so we did this by immunostaining. So on the left-hand side, we have the GFP-positive green-tagged cells, and we also stained for MBP, which is myelin basic protein, so this is a marker of myelin, and these GFP and MBP-positive stains were co-localized, meaning that these GFP-transplanted cells were producing myelin. And furthermore, these co-localized signals were in close opposition to the NF200 positive endogenous neuronal axons, which shows that there was remyelination occurring. Now, on the other hand, we also aim to perform electron microscopy. So on the right-hand side, we have these electron micrographs, which show you can see a bunch of black dots that are scattered along the image. And so these are the transplanted cells that were tagged with these black dots. And essentially, you can see that there are also, so in the middle image, the left electron micrograph, you can see that there is a thin lamellar structure that runs along the center of the image. And so this is indicative of new myelin forming. And you can see that these black dots are found in close proximity to this thin lamellar structure. So again, that's indicating that remyelination was occurring. Now, that being said, the formation of a glial scar is another consequence of spinal cord injury. And so this introduces barriers following injury, just because this glial scar forms this barrier across which the regenerating circuits can't cross. And so what our lab and others have found in the past is that transplanted cells have actually been able to reduce astrogliosis following injury. So we aim to assess whether our ONPCs were also capable of doing the same. So in fact, we did find that the ONPC group gave rise to reduced astrogliosis in the blue compared to the vehicle group in the gray and in the orange. Now, moving forward, we also wanted to assess the histomorphometric status of the tissue. And so on the left-hand side, we have representative images from the ONPC group. And on the right-hand side, we have the quantification of these stains. And what we found was that the ONPC group had significantly lower lesion volumes at the injury epicenter in comparison to the vehicle group. So I just commented on a bunch of the pathophysiological effects of ONPC transplantation, but we ultimately also wanted to assess functional recovery. And so first of all, we did this by assessing forelimb function using the forelimb grip strength meter. And what we found was that the ONPC transplanted group performed significantly better over the course of the study in comparison to the vehicle group. So in this image, the ONPC group is seen in the red, whereas the vehicle group is seen at the bottom in the gray. Furthermore, we also aim to assess the gait of the rats, and so we did this using the catwalk gait analysis system. So this is essentially a system, it's an automated system in which these rats can traverse a platform, and this platform is automated, and so it tracks their movement. And so using this system, you can track different parameters such as stride length and swing speed. And so on the left-hand side, you can see the patterns from their gait in the vehicle group and the ONPC group. And in the vehicle group, you'll see that the parameters or the different patterns seem to be more inconsistent. Whereas when we quantified these parameters, we found that several parameters, such as forelimb swing speed, hind-limb swing speed, as well as hind-limb stride length, were significantly better in the ONPC group. So in conclusion, what we found was that these human ONPCs were biased along the oligodendroglial lineage, both in vitro and in vivo. We furthermore found that they were associated with several pathophysiological improvements, including remyelination, reducing astrogliosis, and reducing the lesion volumes. And ultimately, we found that ONPC transplantation was associated with functional recovery. So with that in mind, I would like to acknowledge my supervisor, Dr. Michael Failings, for all of his support, as well as all of the co-authors of this work, which are outlined here, and of course, the funding agencies that have made this work possible. Thank you.
What incredible work. I'd like to invite Dr. Carol Swallow to be our discussant.
Congratulations on a really lovely study. Very nicely presented. I have 3 questions. First, a short methods question. Just wondering about your decision to use vehicle as a control instead of NPCs.
Yes, so we did use NPCs in a previous study, and so we did find that the ONPCs were significantly improved over the NPC group. So we have done that analysis before.
In vitro or in vivo or like?
Yeah, so that was done in vivo. It was done in a thoracic model of spinal cord injury. However, yeah, definitely NPC group is definitely something that is important.
Okay. And then also, what's the cell fate for these ONPCs once they're transplanted? How long do they last? Because I know there's some concern about maybe some safety issues with genetically modified NPCs in the past. Does this small molecule result in any kind of sort of
That's a good
worrisome
question.
features?
Yes, so we did look at the transplantation of these cells in non-skid mice to assess the tumorigenic potential of the cells at a long-term point, and we did find that they had a Ki-67 proliferation rate of about 2%, which is quite low, and so they didn't seem to form any sort of tumors or anything like that.
And then finally, what's your vision for how this would be used clinically? I mean, whose NPCs would be sitting there on the shelf ready to be used in the traumatized patient?
Yeah, that's a really good question. I think there's a lot of work that needs to be done before we can answer that question. First of all, it's really context dependent, and all of these different cell lines really behave differently in different types of injury models and so on at different doses and stuff like that. So I think that there's a lot of work that needs to be done before we can go ahead and answer that question.
Okay, thank you.
Thank you.
I think you have one more question from Dr. Harlock.
Yeah, congrats on a nice body of work. Reminds me of some of the work I did with Dr. Failings a few years back. Have you considered a combinatorial strategy, maybe looking at some drugs that augment remyelination, things that have been tried in MS? Have you thought about trying that in addition to the cells?
Sorry, you said combinatorial strategy with drugs that do what?
That augment remyelination in addition to the cells.
So that's not something that we have currently done in the laboratory, but it is definitely something that we could potentially look at in the future. Yeah, so it's not something that we've done in the past.
Congratulations again, and congratulations to all the winners. So that ends the poster session, and I'm delighted to announce the afternoon presentation session. So our first speaker is going to be Keegan Guidolin, who, and he told me how to pronounce this, will speak about porphosome and related nanoparticles for photodynamic therapeutic management of colorectal cancer. Did I get it right?
Good afternoon, everyone. Thank you for giving me the opportunity to share my work on porphosome and related nanoparticles for photodynamic therapeutic management of colorectal cancer. My name is Keegan Guidolin from the Division of General Surgery and the Institute of Biomedical Engineering. My work lies at the confluence of three fields of study, that of colorectal cancer, of nanomedicine, and of photodynamic therapy. So I'll briefly touch on all of these before getting into my work. Firstly, colorectal cancer is a common and deadly disease with over 1 million new cases per year, and which accounts for 5.8% of cancer deaths worldwide. The current standard of care is surgical resection with the potential addition of chemo or radiotherapy depending on the stage and location of the disease. But despite this multimodal approach, we know that there are many challenges that still exist. For instance, cancers that invade the anal sphincter often require removal of the entire anal canal and a permanent colostomy as a result. This has long-term implications on the quality of life and morbidity of the patient. And so we ask ourselves, how might we treat colorectal cancer in a less invasive and more personalized fashion? And one potential solution is the use of nanoparticle technology. Now, nanoparticles measure between 1 and 100 nanometers in at least one of their dimensions, and they preferentially accumulate in tumors compared to healthy tissues. They can be used, therefore, to deliver diagnostic or therapeutic elements to a tumor. Specifically, I work with porphysome nanoparticles, which are composed of porphyrin lipid monomers. And briefly, these monomers consist of a phosphate head, a lipid tail, and a porphyrin ring structure. These porphyrin lipid monomers then self-assemble into a liposomal nanoparticle that we call the porphysome. These porphysomes can be injected intravenously, and when they're done so, when we inject them intravenously, they accumulate in the tumor over time as the nanoparticle circulates throughout the body. Eventually, they're taken up into cancer cells and disrupted into their porphyrin lipid elements, which is their active form. Now, you may be wondering what makes these porphysomes so special, and it's really this porphyrin ring structure. Because when we irradiate this porphyrin ring structure with a laser, we can do two things. Number one, we can produce fluorescence, which we can then use for image-guided surgery, identifying the location of tumors. We can also produce reactive oxygen species. And when we produce reactive oxygen species within a tumor, it causes tumor cell death. And it's this process that we call photodynamic therapy, or PDT. Last summer, we published this paper, which was the first evidence that porphysome-based PDT was possible. In this, we treated mice that had subcutaneous lung tumors with intravenously administered porphysomes, followed by PDT 24 hours later. What we didn't investigate, and what we are doing now, is assessing the impact of the drug-light interval. That is the time between the administration of the porphysome and the administration of the laser on PDT effect. I don't only work with the porphysome itself, I work with a porphysome sort of extended family. And the one that you need to be aware of for this is called the E-porphysome. It's another version of the porphysome. Why this is relevant is because some of these other versions of the porphysome become activated more rapidly than others, as you can see here. So this suggests that other versions of the porphysome with some changes to their formulation might be more useful at earlier time points and have different roles in the clinic. And so my research objective overall was to apply porphysome PDT to the clinical challenges that we have in managing colorectal cancer. To do this, I cultured CT26 murine colorectal cancer cells and injected them into mice to create a subcutaneous syngeneic colorectal cancer mouse model. I randomized these animals into treatment groups with various drug-light intervals and treated them at the appropriate drug-light interval with laser irradiation, and then followed them for 30 days using a survival study model. When we replicated just the results of our past study, comparing untreated animals to the 24-hour drug-light interval porphysome PDT, we found that porphysome PDT results in improved tumor ablation and survival as compared to these untreated controls. This is not particularly surprising, but it's a good validation that this technique works in this new model. When we dig into the drug-light interval interaction, we can see that contrary to what we expected, we actually see that porphysome PDT is more effective at shorter drug-light intervals. Specifically, porphysome PDT at 3 hours drug-light interval produces the most effective tumor ablation. What we had expected was that as porphysome circulated through the body and accumulated to greater degrees in the tumor, that it would therefore have a greater effect at these longer drug-light intervals. But that's not what we found. Further, we found that treatment at 3 hours and 1 hour actually provides superior survival to the group that was treated at 24 hours. When we turn now to the e-porphysome treatment, we found this was optimized overall at 1 hour with the best tumor control at 3 hours or 1 hour. Those were equivalent groups. But the survival benefit was clear with a best treatment at 1 hour. And so when we do a direct comparison between the optimized treatment between porphysome and e-porphysome PDT, we can see that the optimized e-porphysome treatment provides better tumor suppression than the porphysome treatment does. If we take a step back now and look at the optimized e-porphysome treatment compared to untreated controls, it really illustrates the magnitude of this effect. So what you can see here is the control group, which reaches, the tumors reach a volume 10 times their enrollment size by about 6 days after enrollment, whereas the e-porphysome treated tumors are stable in their size largely throughout their entire follow-up period. In addition, all of the animals in the control group required sacrifice by 6 days after enrollment because of their tumor size, whereas many of the e-porphysome treated animals survived to the end of the study. And so we can see that it's significantly better than untreated controls in basically any way you slice it. And so this data suggests that we can treat patients using PDT in a single outpatient visit rather than requiring a prolonged drug-light interval, which is what we had thought before. And so the next question is, what challenges might we encounter when we take this in practice? And to assess this, I created a new model of an orthotopic model of human rectal cancer. So I injected human rectal cancer into the rectum of rats to create the rectal tumor that you see on the right side of the screen here. I randomized these rats to either receive no treatment or to receive porphysome PDT at 24 hours as per our original study. And I also used what I imagine to be a clinically relevant treatment modality for delivering the light, which is a transanal intraluminal laser irradiation scheme. So I placed the fiber optic directly adjacent to the tumor, essentially, and turned on the laser to deliver that radiation. What we found is that intravenous porphysome PDT is effective in treating these tumors. You can see a sharp decrease in the size of the tumor in the first few days after treatment. However, this results in unacceptable adverse events. So as you can see, the response is quite robust. You have edema and erythema in the first few days, followed by sloughing and necrosis of the rectum, and eventual formation of a rectovaginal fistula in a lot of these patients. So clearly a barrier to translation. So now the question is, how can we limit these off-target effects? Because what we really want is for all of the porphysome to be localized to the tumor. In reality, however, the porphysome is present in both the tumor and the healthy tissue. It's just present in the tumor to a greater extent. And so I thought, well, why don't I just directly administer the porphysome to the tumor itself? And so that's what I did. I used the optimized regimens that we had, the 3-hour drug-light interval. I used porphysome and e-porphysome, and I randomized animals to this group. You can see on the left the pre-treatment animal with the dark green porphysome staining around the anus. And on the right, you can see that I devised a customized laser sheath that would shield the anterior structures and direct the light posteriorly towards the location of the tumor. And so when I did this, I found that peritumoral porphysome PDT and e-porphysome PDT are both effective in treating these orthotopic human rectal cancers, equally so, and better than the control group. And more importantly, though, I found that this resulted in no off-target effects and was generally well tolerated by the animals. And so in conclusion, I found that porphysome-based photodynamic therapy can be used to ablate and suppress colorectal tumors and improve survival in these animal models at least. and that I can also use photodynamic therapy to, I can effectively deliver it to rectal tumors via this transanal intraluminal irradiation, in sort of a minimally invasive technique that you can imagine applying in your endoscopy suite, for instance. If we look at the big picture now, we've known about photodynamic therapy as a modality for a long time. It's been investigated with favorable results in colorectal cancer, but has not been widely adopted. And I think this is a real shame, because photodynamic therapy has the potential to be an entirely new modality to use in the treatment of colorectal cancer. There are lots of clinical challenges that we have right now. For instance, we could use it to ablate unresectable polyps, for sphincter preservation in low rectal cancer, or for palliation in cases of unresectable cancer. And ultimately, I'd like to see PDT join the ranks of these other modalities to create a new multimodal approach to the management of colorectal cancer. I'd like to acknowledge my supporters, both financial and academic, and I'm happy to take your questions.
That was fantastic. I'd like to invite Dr. Margaret Akins to be our discussant.
Hi, Keegan. It's very, very excellent presentation and great work. And I agree with you to add PDT to the other treatments modalities. I have a few questions. You mentioned that when you treated the animals, the tumor size shrunk. But as you may know, tumor size is not equals tumor viability. Did you do any other evaluation to see how many of the tumor cells survived and would still create a new tumor growth?
Yeah, so it's a good question. We've done histological investigations to look at the degree of necrosis, but in addition, because we devised this as a longitudinal survival study, the PDT effect is maximized at about 4 days, and after that we see basically that any tumor cells that are still present at the end of our 30-day follow-up are all viable. And so we got around the question of, well, are there non-viable tumor cells still in the tumor by just essentially waiting it out?
Okay, and my next question is, in your subcutaneous model, you used a murine cancer cell in the mouse, but for your rat autotopic model, you used the human cell cancer cell line in a rat model, and an immune-compromised rat. So do you expect that because the immune system is also activated by PDT, if there's a difference in the reaction and how that would translate to the patients later?
Yeah, it's an excellent point. So PDT is, as you say, activates the immune system. We are investigating that, and I mean, ideally, we could investigate the effect of the immune system on a human colorectal tumor in a preclinical model, but we don't have that capacity, right? So these are sort of complementary models. We use the syngeneic murine model for that exact purpose so that we can assess the immune reaction to it. We're working on some flow cytometry and other immune type studies to see the contribution of the immune system to the effect for porphosome versus e-porphosome PDT. But obviously, we would expect that effect to be significantly reduced in the nude rat model. So we're missing that piece, but we have to balance between, do we include the the immune system, or do we try to address an actual human cell line?
Okay, thank you very much.
Thank you.
Next, I'd like to invite Dr. Brianna Greenberg to present her quality improvement study titled A Completely Honest Evaluation of Surgical Tube Thoracostomies by Trainees.
Hi, I'm Brianna. I'm going to be talking about the completely honest evaluation of surgical tube thoracostomies by trainees, the CHEST project, one of our quality improvement projects. I'd like to thank the committee for letting us present our research, as well as acknowledge all of the amazing people at Sunnybrook that have allowed this to continue. So no disclosures to start. So pretty much tube thoracostomies, they're very important with chest trauma, especially at Sunnybrook Hospital. They have complication rates up to about 37% that we've seen in the literature. Iatrogenic injury, increased length of stay, increased costs associated, as well as reinsertion rates. From our preliminary research, we've noticed that there's been an up to 21% reinsertion rate. The literature has also showed that structured training programs have actually been helpful to minimize these complications. And finally, what we're doing is we're using video review to improve real-time chest tube insertion in the trauma bay. This is yet to actually be studied with QI methodology. So what has been done so far? I'm not going to go through this entire table, but essentially there have been checklists that have been developed and validated to evaluate trainees putting in chest tubes. They've established passing scores to determine competency of these residents, or of these trainees, but some of them have used video review and some of them have not. Video review in a simulated setting has been seen in the literature, but in our case, we're going to be in a non-simulated trauma setting, which makes it unique. Also, we'll be doing it on live patients as opposed to like porcine or mannequin models. So just briefly, what is trauma video review? At Sunnybrook, trauma video review has been going on for a couple of years. It's been approved by the hospital for trauma video review rounds that occur every month to see how things are going in the trauma bay. We're going to be using it to observe these tube thoracostomies placed by trainees in non-simulated trauma settings. All the trainees that are actually rotating through Sunnybrook on the general surgery service are being subject to this observation, and we're going to be including all of them in our data. Finally, we're using a checklist that is both technique-centered and patient-centered, which is kind of the whole thing about quality improvement research. It's also about the patients as well as how are we performing these chest tubes. And finally, we're able to identify issues that are specific to our trainees at our institution and use that to identify ways to improve upon them. So just a quick disclaimer, this is a very early pilot project. It's part of the Plan, Do, Study, Act cycle. We're only in the developmental phase, and these are very early results. But essentially what we're doing is we're looking for red flags with chest tube insertions, correlating them with poor placement on x-rays. From this, we're going to be able to develop and implement targeted interventions. And then finally, moving forward, we'll be looking at the trauma video reviews again to assess for any improvement. So in terms of our methodology, we've had 13 videos for the pre-intervention group, which was about 14 chest tubes. And from that, we were able to identify very significant quality issues. It was through a variety of residents from multiple surgical backgrounds, emergency medicine backgrounds, family backgrounds, at different levels of their training. We're using similar cohorts pre and post-intervention. And finally, in terms of our inclusion criteria, it was all adult traumas that came into the trauma bay that needed a chest tube. And in terms of exclusion criteria, it was anyone who came in extremis or peri-arrest or pericardiac arrest. So the first phase, which we've essentially completed, was where we had 3 experienced trauma surgeons develop a checklist that we are to follow during the trauma video review. And then by using these checklists to review these residents putting in their trainees, we've come up with red flags that have correlated with poor placement that are literally being seen on the chest x-rays after they've been inserted. So just these are just the checklists that we created. They're similar to the checklists that are out there in the literature. So it's essentially based on preparation, patient analgesia, comfort, consent, and then we have criteria that you have to meet when you're actually inserting the chest tube, as well as post-procedure criteria as well. So some pretty shocking things we've seen. Residents have trouble putting in chest tubes. Consent wasn't taken in around 10 of 14 tubes, which says a lot because oftentimes patients are still in capacity and you are able to actually tell them what you're doing. Sterility not being maintained has well been a huge issue, as far as anywhere from drapes being out of the place or people using blue gloves to actually do the thoracostomy part. And improper sharps disposal as well, huge issue with sharps being placed on the bedside, on the patient's abdomen, by their head, just very shocking type stuff. From a technical standpoint, we identified 5 factors that would correlate with successful placement of the chest tube: patient position, landmarking, incision, amount of tube in the chest, and the actual ease of placement of the chest tube. If all 5 of these were there, then there was a 91% chance of your chest tube actually being in a good spot. And I just wanted to show some of the pre-intervention chest tubes that we saw. So some of them, even the top left, completely extrathoracic. Obviously, going into the fissure is a common issue, but then, kinking at the mediastinum, not all the holes in the chest. So there's been some pretty shocking chest x-rays after these insertions. Phase 2 was our intervention, so we decided to start with some didactic teaching as well as an actual simulated session at Sunnybrook. So it starts off with 15 minutes of just tips and tricks of how to put these chest tubes in, followed by an actual simulation from start to finish, gathering your supplies, getting gowned up, to actually closing and suturing off your tube. From what we've noticed after only 2 interventions, that we've seen chest tube scores improving from around 71% up to 88%. So this is just showing how the red flags have actually reduced post-intervention. So more people are getting consent, a little bit of change in pain, sterility is improving, as well as sharps disposal is improving. And then I also split the data just preliminarily to see does this matter if the patient is incredibly unstable or not. Again, they're not an extremis, but if they're on massive transfusion protocol or if they're transient responders, you can still see that following protocol is appropriate, we can do it. We can see improvements in where the chest tubes are placed. It just takes to be thoughtful and systematic with the insertion. So what do we know so far? Video review has helped to identify problems with tube thoracostomies by residents of all levels and all experiences. Even after a single hands-on session, you're seeing improvements in chest tube places by trainees. And finally, by identifying these predictors of poor placement, we can hopefully intervene earlier in the actual trauma bay to prevent the potential morbidity from insertion. So in terms of our future directions, again, this is very pilot, like we're all just kind of starting this out, but we're hoping to be able to introduce chest tube QI rounds. We're hoping to introduce like a chest tube supervisor, somebody who has reached competence and is able to actually guide the insertion if we need them. A pre-insertion pause by TTL would be awesome to control pain, to make sure the indication is clear, we're on the right side, et cetera. And then ultimately, like a standardized documentation form to improve documentation would be great, as well as for the trainees to see what steps they need to make in order to achieve the quality of chest tube insertion. So some limitations. It's a pilot study to start. We only have a very small cohort of residents for a pre-intervention phase. We also have the issue of new residents coming in every block, so our post-intervention residents aren't going to be the same as our pre-intervention residents, but we're hoping a representative sample is achieved by continuing this per rotation. The Hawthorne effect is also there. Once residents know they're being watched, they're probably going to be a bit more careful. But at the end of the day, this is about improving the placement of these tubes, improving the patient care behind them. Finally, later cohorts coming into the study will have probably more experience with their chest tube insertions, so we might see higher pre-intervention scores. Ultimately, though, post-intervention, if the chest tube's in the right spot and the patient's okay, that's what we want. So thank you so much. I'd like to acknowledge all the Sunnybrook people. They helped me with all of this research, and it's been going so great.
Nice work. I'd like to invite Dr. Marcelo Seipel to discuss this paper.
A really nice presentation. I think it's very important to have these educational activities. So I just have a few questions. For the video recording, like how close you can see the actual procedure when you're evaluating how the performance of each individual was?
Yeah, that's an excellent question. So there are some videos where it's definitely not easy to tell, especially when the ones that are going like super fast and there's a lot going on. But you're pretty much seeing the entire trauma bay because they are used for everything else. So when there are tubes that are kind of harder to decide like how, is the stitch in the right place? Are the drapes in the right place? Then we can't really use them as well, but there weren't many like that. So I would say overall we were able to kind of see pretty clearly everything that was going on.
Okay, thanks. And in terms of consent from patients, I'm not talking about the consent to insert the chest tube, but the consent of the patients to be recorded in a video and being used for these education activities. Is that any specific consenting process for that?
Yes, also a really good question. So given that the trauma video review program has been at Sunnybrook for over 2 years now and is already being used by the trauma surgeons there to kind of assess how things are going in the trauma bay on a monthly basis, it's almost like implicit that this research, as long as it's still being used for QI purposes and we're not having any patient identifiers and we're still following standard of care with our chest tube insertions, that we're able to use the video review for the QI research in that regard.
Okay, and then finally, do you think you need to tailor the training process for the different levels of, residents and other people in the ER. Because I think when you're just starting to put a chest tube, you just want to do it safely and effectively. Once you move with more experience, you want to have the patient have that experience with zero pain as well, and I think we can achieve that. So you may need to have a different approach for a different level of trainees, so just wondering.
Yeah, no, that's also a really good question. So for right now, we've kind of grouped all of the resident training levels kind of into one. And to be honest, we have seen poor scores in PTY5s and PTY4s, et cetera. So I think at the start, we're just trying to make sure our checklist works. And then moving forward, we'll be able to identify from resident feedback as well, like what areas specifically do they think they should be working on in that context. And then ultimately, we'll be able to analyze by specific level to see, how people are doing compared to each other.
Thank you. Yeah, great work.
Thanks, that was great. Our next presenter, thank you. It's very thoughtful. Our next presenter will be Dr. Jeffrey Zuccato, who will be teaching us about the diagnostic utility of DNA methylome-based liquid biopsies of CSF for malignant brain neoplasms.
Hi, thank you for the introduction. So I'm looking forward to talking to you today about our DNA methylome-based liquid biopsy approach for malignant brain tumors using CSF. So first, I just want to establish that the treatment of brain tumors depends on precise neuropathological diagnosis, and this is done histopathologically, or more recently, the German Cancer Research Center has published a brain tumor classifier that relies on DNA methylation alterations that can be used together with histopathology to make brain tumor diagnoses. But all of these approaches depend on a tissue sample obtained with a neurosurgical procedure that carries risks to patients and has associated patient morbidities. And so this has led to interest in looking at non-invasive approaches to diagnose these tumors. On the left, I show non-brain tumor patient diagnosis using plasma circulating tumor cell-free DNA. And on the right, some work from our lab looking at plasma-based diagnosis of brain tumors. This work here looks beyond plasma, looking at CSF-based liquid biopsy for CNS tumors, which has potential advantages over plasma relating to the higher abundance of circulating tumor DNA, as CSF is more proximal to the tumor, as well as reduced presence of other non-tumor DNA that's present in normal plasma. And really the goal would be to, showing at the bottom here, hopefully it's visible, is some of our existing work using plasma-based approaches for gliomas that show AUC accuracy values between 0.7 to 0.8, and the goal would be to use a potentially more useful biofluid or more accurate biofluid to improve on this accuracy. So CSF liquid biopsies for brain tumors have been published that rely on genomic alterations as opposed to DNA methylation alterations, which have limitations associated with the presence of any one mutation within only a subset of any given tumor type. Whichever tumors do not have that alteration would not be detected, and you wouldn't know this up front at the time of diagnosis. And then secondly, the low abundance of any one alteration. And so our approach uses multiple different methylation signatures across the entire genome, and so the detection of any one tumor does not depend on any one biomarker being either actually present or detectable in that specific tumor. And so malignant intraaxial brain tumors are an ideal set of tumors to study CSF liquid biopsy for. These are brain metastases, glioblastomas, and CNS lymphomas that are all common, malignant, aggressive, and poorly prognostic brain tumors that are unfortunately not reliably distinguished using standard of care MRI, as I show in the figure in the middle, accuracy ranging from 70 to 80%. And so typically, or standard of care is to obtain surgical biopsies, as I mentioned at the beginning, to coordinate optimal care, as many brain metastases can be candidates for radiotherapy. Typically, glioblastomas undergo surgery and lymphomas are treated with systemic therapy, so the treatment can be very different depending on the diagnosis, and that's why it's important. And so the study objective here is to establish the utility of CSF methylomes for classification of malignant brain tumors non-invasively to improve upon these existing approaches, with aims being first to to compare the utility of a CSF versus a plasma-based approach, and then secondly, to utilize tissue DNA methylation alterations to assess and optimize the CSF approach. This is the study cohort. It includes CSF and plasma samples across all three entities that are frozen biobank samples, as well as tumor tissue samples that are either frozen or paraffin-embedded samples from the Department of Pathology, and we also take advantage of external publicly available data sets of brain mets and lymphomas to enhance our cohort numbers. This is the workflow of sample processing on the left, showing biofluid sample processing, where cell-free DNA is extracted, methylated cell-free DNA is immunoprecipitated, and then sequenced. And on the right, showing the workflow of tissue samples where DNA is extracted by sulfite converted and then profiled in the Infinium EPIC array, and our local samples were combined with those publicly available samples at that point. So now, the first aim to compare the utility of a CSF and plasma-based approach. On the top left of the screen, I'm showing the amount of cell-free DNA present in CSF that is higher than that which is present in plasma and insufficient for the first time we've looked at this to go forward with the protocol. Secondly, on the right, I show the bioinformatic classifier development approach that was done independently for each biofluid. And basically what it shows is that each of the three tumor types are split into an 80% training set on the left side of that flow diagram, and then a classifier is built using differentially methylated regions between each of the three tumor types. And that model is then evaluated on the independent 20% of samples on the right side of that flow diagram. And this process is repeated 50 times for estimates of dispersion of the performance metrics. On the bottom of the slide, I'm showing the CSF on the right and plasma CSF on the left and plasma on the right. Using the features that were identified during model building, we first produced MDS plots that show clustering of the samples using these features in both CSF and plasma. And then we, again, using the features that were identified during model building, we then performed hierarchical clustering, which you can see on the right side at the bottom, where the features in CSF are more distinct than the features in plasma that you can see by comparing the two colors. Then we looked at evaluating these models in the independent testing sets, which were not used to build the models. On the right, I'm showing the plasma-based models differentiating these three malignant brain tumor types, showing AUC accuracy values between 0.7 and 0.8, as I described we had showed previously. But we've now, in other tumor types that we've now clarified here. And on the left side of the slide, I show the cerebrospinal fluid CSF-based models showing accuracy around 0.9 or above and below 0.9, representing the increased accuracy of these models compared to previously shown approach. The next step is to utilize the tissue methylation data and differences between tumor types in tissue, and then to assess the CSF-based approaches and to optimize that approach. So this slide hopefully is okay to visualize, but basically what I'm showing here along the x-axis is the tissue methylation signatures that are specific to each tumor type, and along the y-axis on the top I show tissue signals, tissue methylation signals in CSF, and at the bottom on the y-axis I show tissue methylation signals in plasma. And really the point of this is to show that there's a greater correlation between tissue signals and CSF signals than there is in plasma, and this likely relates to the increased proportion of tumor DNA that gets into the CSF. This is utilizing the tissue data for independent evaluation of our CSF-based features. On the left side of this slide, I'm showing an MDS plot of the tissue data using independent features from the CSF data set that were used for our model building. And the point of this is to say that we identified a bunch of features in CSF, and now we show that those features can cluster tissue samples by tumor type independently to kind of validate these features and show that they're tumor specific and not dependent on other non-tumor features that may be present in the CSF. And then on the right is essentially the reverse of this, showing that the tissue, if we identify features of each tumor type in tissue and then we look for those tissue features in CSF and plasma, we see that they're they're more highly identified than that. So for example, on the left side in the brain metastasis figure, you can see, it's so difficult to point here, but you can see that that bar on the left side in the brain metastasis plot in the middle is highest in CSF, and you see that brain metastasis signatures are more highly identified in brain metastasis samples than the other tumor types. And this is also seen in glioblastomas and CNS lymphomas. So we see tissue signatures are identified in CSF, and then greater than what we see in plasma. Then based on this, we rebuilt our CSF-based models, now limiting them to those features that are present in both the CSF data set and the independent tissue data set. They're differentially methylated between tumor types in both independent data sets, and by using these models, we see that the accuracy of the models approaches 0.95 in some of the tumor types, where two of the three tumor types where I showed 0.9 on average before. And this is some representative cases to show you that on the left, you can see that these three cases where the tumors are difficult to differentiate on neuroimaging, but the CSF-based models accurately identify diagnosis in these representative cases. In conclusion, what I've shown is the first use of a CSF methylome-based approach for liquid biopsies of malignant brain tumors. And then I showed that the accuracy of a CSF-based approach is higher than a plasma-based approach. And this approach also addresses limitations associated with other existing literature using CSF for brain tumor liquid biopsy that relies on genomic alterations that have limitations. And we do this by having a large set of features that we don't rely on any one feature being either present in a tumor or present in that sample. And then I think these CSF classifiers hold promise for avoiding risks of invasive neurosurgical biopsies in patients who are amenable to non-surgical treatment, including brain metastases and CNS lymphomas, and to diagnose otherwise unbiopsiable tumors. And future work, ongoing work, is looking beyond diagnosis in our lab and to look at alterations that can be used to predict recurrence, to look at progression. So I'd like to thank, of course, Dr. Zade for all of her extensive supervision and mentorship, other lab members and collaborators.
That's very impressive work. I'd like to invite Dr. Stephen Gallinger to discuss.
Thanks, Jeff. That's it's great to see great stuff from GallieDay's lab, even more. I guess it's pretty intuitive that you'd expect the CSF signal to be higher, so I accept your conclusions, and I'm not all that surprised. And I guess the main point is, so the argument is that you don't need a tumor tissue biopsy once you get this rolling with using your training test set. You've developed an algorithm that you think is prospectively going to pick up the right kind of tumor, right? Is that the argument?
Yeah, I mean, this requires prospective validation, but I think when we apply it to a prospective cohort, we would expect similar accuracy in identifying diagnosis.
Yeah, so with that in mind, so what are you doing prospectively? Because, the biomarker world is really tricky and complex, and, the burden of proof is always on the person who's doing it prospectively. So is that what you're doing now?
Yeah, so part of this is, I mean, these are all retrospectively collected samples, and sort of we up until now we haven't been prospectively evaluating samples. So now, based on this, we're going to start to collect and sort of evaluate things prospectively as well.
Okay. And I guess I had a bunch more, but I won't saturate. The methylation signature comes from the MEDIP profiling, and those are genes that are presumed. I know the MEDIP world doesn't worry too much about what genes are causing the signal, but from a discovery point of view, have you looked, or are you looking at the genes that are represented in the MEDIP signal?
Yeah, so what we did here was first look at the differentially methylated regions in the CSF, and then we also looked at ones that are differentially methylated in the CSF and the tissue. So it's difficult so that's kind of getting towards your question. It's difficult in the CSF to figure it out because it's a methylated DNA pull down. So you have a cell-free fragment of DNA that's pulled down because it has a methylated CpG somewhere on it. It's hard to localize exactly where on that which gene is actually methylated, or which presumably gene promoter is methylated on that fragment. You just know that something on that fragment was pulled down. But then tying it back to the fact that we do see optimized models when we limit that down to features that are also present in tissue, the next step which we're looking at now is to try to look at the tissue level, what are some of the genes that are differentially methylated that are responsible here. So that is the next step and something that we can, it is difficult to do in the meetup data, as you said, but able to be done in the tissue, which we'll do next.
Thanks. It's great stuff. Thanks.
Thank you.
Thanks, Jeff. Great work. Since these specimens were collected retrospectively, you may not know the answer, but when was the CSF drawn? Prior to surgery or during the surgical case? And
yeah, so that's one of the limitations here. And this is something that we obtained from our collaborators, essentially a combination of samples that were obtained either by lumbar puncture, or some of these samples were obtained through intrathecal catheters when tumors were, many of the ones that were not done by lumbar puncture were done where in centers where tumors were treated with intrathecal chemotherapy as a potential therapeutic approach. And so we were able to get the samples for that reason. And so many of them were either at the time of diagnosis from LP or later during the course prior to intrathecal treatment.
Because I imagine large mass effect, papilledema, doing a lumbar puncture might be, in some cases, prohibited, right? That might be a limitation of drawing CSF.
Yeah, for sure. So I think going forward, the way to do this may be to potentially start with a plasma-based approach, see what the result looks like. I mean, as this kind of goes forward and we understand some of the sensitivity, specificity, positive predictive value, et cetera, start with a plasma-based approach. If you get indeterminate diagnosis, maybe go forward to a CSF-based approach if it's feasible and safe. And if that's sufficient, then great. Otherwise, potentially, either if it's unsafe, like you said, or sort of indeterminate results, not consistent with clinical course, then maybe you'd go to a surgical approach at that point.
And then have you looked at recurrence or relapse? It would be great if you had data to show that, let's say the metastasis or the glioblastoma was resected completely, CSF returns to normal, and then you could just use a lumbar puncture to see if it's tumor coming back as opposed to radiation necrosis or something like that.
Yeah, for sure. So that's something that we're definitely exploring, is kind of a longitudinal serial assessment of samples throughout the course of disease, initially at the time of surgery, then after surgery to see that the signal comes down, and then later during recurrence. That's what I was kind of mentioning in the next steps. We've done that in plasma, and we have shown that that is something that occurs, and it is something that is feasible. If you do see the signal come down, which you do in many of the samples, often it does come up at the time of recurrence. It's something that we don't have sufficient samples yet to do in CSF, but it is a next step that we're planning to do.
Thanks very much.
Thank you.
Our next presenter is Rafaela Ribeiro, who will be teaching us about donor inflammatory signature during ex vivo lung perfusion and how it's a potential approach to predict CMV development following lung transplantation.
So thank you very much for the opportunity to sharing our work here today about looking into donor-derived inflammatory signature as a potential approach to predict CMV development following lung transplantation. And really, CMV is extremely prevalent worldwide. And specifically, if we look at blood and organ donors, this prevalence is as high as 80% around the world. And really, for healthy individuals, this is not an issue as they clear infection quite quickly. However, for immunocompromised patients, with lacking immune system, robust immune system, this can be quite a problem because CMV will infect different types of cells, which can culminate into life-threatening tissue-invasive diseases like hepatitis, pneumonitis. And really, the risk of CMV disease is highest in CMV seronegative recipients without pre-existing CMV-specific immunity who receive a latently infected organ from a CMV seropositive donor. And lung transplant recipients specifically, they develops the highest rates of infection and disease. So without prophylaxis, up to 92% of the high-risk patients actually develop viremia, and 50 to 65% of these patients will actually have symptomatic infection by 90 days post-transplant. And for the intermediate risk patients, so the seropositive recipients, 40 to 60% of them, they actually develop viremia as well. But most importantly, CMV has been associated with chronic lung allograft dysfunction, which will end up resulting in decreased survival in this lung transplant recipients. So the strategy really is to extend and do a really extensive antiviral prophylaxis for up to even 12 months, depending on the centers, to try to avoid viremia post-transplant. However, recent data shows that as soon as you stop prophylaxis, you still end up developing viremia for the high-risk patients as up to 50%. And this really happens because CMV has a really interesting life cycle where it has a latent and a lytic infection. And really this antivirals, they only target the lytic replicative status of the virus. So it really never clears this latent burden. And CMV reactivation is extremely complex and driven by a diverse array of stimuli. And really, the major actor here is the major immediate early promoter, which during latency it's occupied by histones with repressive modifications. And then for reactivation, this reactivation is triggered by reprogramming this promoter such that the repressors are replaced by activating transcription factors and co-activators. And really this trigger comes from diverse stimuli, so like inflammation, growth factors, DNA damage, oxidative stress. And really, organ transplantation itself is an environment of injury. So there's ischemia reperfusion injury, and all of this can somehow help in the mechanism of reactivation of CMV. To meet the growing demand for lung transplant procedures, ex vivo lung perfusion, or EVLP, has increased the utilization of high-risk extended criteria donor lungs. And EVLP is a clinical method used to assess and condition donors prior to transplantation. And lungs are perfused and ventilated ex vivo at body temperature in a lung protective physiological condition. And really, this platform technology has pretty much doubled the number of transplants in our institution without really having any negative impact in survival. So the long-term effects comparing EVLP versus non-EVLP donors are pretty similar. But for us specifically, we were interested in looking at how, if there is any impact on CMV outcomes from using this more injured and with tissue damage type of organs. And we did investigate this, and we didn't see actually any difference in incidence of CMV when comparing recipients from EVLP to non-EVLP donors. So the incidence was pretty similar, however, it was still common and high in the high-risk patients, so basically the donor-positive kind of constellation. So this really underscored the need for predictive biomarkers or even treatment strategies even before transplantation. So that took us to our main hypothesis here, is that measuring donor-derived inflammatory proteins in perfusate samples during EVLP can help identify higher-risk donor lungs for CMV development post-transplantation. And the aims here were to compare CMV seropositive donor lungs inflammatory profile between viremic and non-viremic patients post-transplant. And evaluate the association between this perfusate inflammatory cytokines and CMV-related outcomes post-transplant. So we did here a retrospective analysis, including all clinical EVLP cases from CMV-positive donors from October 2010 to January 2020 in our institution. Perfusate samples, they were collected normally as per our clinical protocol, snap frozen in liquid nitrogen and stored in -80. And we designed a 15-plex multiplex panel to look into this inflammatory profile, comparing the viremic and non-viremic patients. So within the study period, there was almost 400 clinical EVLP cases performed, of which 204 were from CMV-positive donors. One was excluded from the study due to lack of availability of perfusate samples. So within the 203 CMV positive donors, 108 patients became viremic post-transplantation, and 95 did not become viremic. And just of note here and importance that CMV viremia here was defined as CMV PCR greater than 1,000 international units at any time up to 2 years post-transplantation. And just here looking at baseline patient characteristics for donor and recipients, both groups, viremic, non-viremic, pretty similar. Here we do see a bit of older population in the viremic patients, however, probably not clinically relevant, 49 versus 44. And then regarding recipients, we do see here too a higher male sex population in the viremic patients. But I think most importantly here is that both groups are equilibrated in the sense of the CMV serostatus, since we know that this is really the status, the matching status of donor and recipient is one of the most important risk factors for CMV development. So from this 15 plaques panel, so we really started with a straightforward approach, just looking at the protein levels of all of these proteins in the viremic and non-viremic patients. And from the 15 plaques, well, we did see differences in IL-7, IL-12, and interferon gamma concentrations, where IL-7 and IL-12 was higher in the viremic patients. On the other hand, interferon gamma was lower for these patients, which are in pink here in the graphs. So then we moved on to do a bit of a more robust type of analysis and to be able to control for a few factors. So looking into univariate and multivariate logistic regression to look into viremia and all these biomarkers. So IL-7 again seemed to be significantly associated with viremia. And after adjusting, it was still significant. Then we really wanted to look more into the viral kinetics and the levels of this biomarker. So one really important thing in CMV post-transplant is looking at freedom from CMV or time to viremia post-transplantation. And in a univariate analysis, we did see that IL-12 and IL-7 again was associated with earlier time to CMV development. So we decided to assess a bit better the validity of both biomarkers to predict viremia. So we did ROC analysis and defined optimal cutoff values. You can see here that for IL-7, there was an accuracy of 62%, and the optimal cutoff point was 15.41 picograms per mil. For IL-12, the accuracy was 59% and the optimal cutoff point 3.12. And then we stratified the analysis in these groups based on these cutoff values, and really interestingly, we found a strong correlation when looking at so above or below these cutoff values for IL-7 on the left and IL-12 on the right. There was a real difference in development of viremia. So the higher level donors actually had earlier development of viremia with a strong hazard ratio. However, when doing multivariate regression, it was close to significant, but not maybe a sample size issue. So what we decided to do was actually combine both high levels of IL-7 and IL-12 and do the same type of analysis. And then here again, we did see that combining both in the high level range provided with a hazard ratio of 1.8 for time to viremia. And after adjusting, it was still pretty significant with a hazard ratio of 1.8 as well. However, it's interesting to point out here that when looking at this cutoff values, combining both biomarkers and looking at survival, so time to death, there was no difference. So it didn't implicate in a poorer survival here. So as summary and future directions, so IL-7 and IL-12 were here identified as biomarkers with a potential to predict CMV viremia development post-transplant. High levels of both biomarkers are strongly associated with early development of CMV, suggesting maybe some sort of implication in virokinetics, but these mechanisms need to be further elucidated. And here we haven't stratified the analysis by disease status. So CMV has a different spectrum post-transplantation. So you can have viremia alone, which is what was looked into here, but you have CMV syndrome, you have tissue invasive disease. And I think this type of stratified analysis will help to understand better the clinical implication of these biomarkers. And these biomarkers, if further validated, could be used to tailor treatment, a specific treatment and even management of this higher risk patients for CMV development. And just of interesting note here in this particular point, we have investigated in the past a novel chemokine-based immunotoxin which targets specifically latently infected CMV cells. And we actually delivered this, which is called F49A FTP. We delivered this immunotoxin during EVLP to human donor organs, CMV positive, and we had controls as well. And what we saw that this F49A actually demonstrated a median reduction of 76% in viral reactivation, which was really interesting. And we also, we didn't see any acute effects from this novel potential approach to treating latent CMV prior to transplantation, which after identify the higher risk patients could be an interesting clinical application in the near future, hopefully. So with this, I just want to thank my supervisor, Marcelo Saipo, the entire lab, and open to any questions.
Very nice presentation, and I'll invite Dr. Tom Waddell to be the discussant.
Thank you very much, Rafael. I really enjoyed your presentation. As usual, it was excellent. I do have some disclosures. I have equity interests in EVLP, as do your supervisor and others. I think everyone knows that. But I thought it was a good presentation, but let me come back to the basic hypothesis. The hypothesis is that inflammation of the donor lung somehow creates an inflammatory milieu that then promotes CMV reactivation. And you show that EVLP as a whole doesn't follow that thinking. Maybe that's because EVLP actually reduces the inflammation. But more directly, like, is there a correlation between PGD3 in the recipient? For whatever reason, whether it's donor-related or recipient-related, somehow there's an inflammatory injury. Does that correlate with CMV reactivation?
So there are a few studies, PGD specifically no, but some large data sets, what they see is basically ischemic time does correlate with CMV reactivation. PGD, I'm not too sure. From what I recall, there's no clear correlation with reactivation.
Thank you. A second question is about the viral burden. Obviously, the two donor groups, one recipient positive, the other recipient positive, but the only difference is the donor positivity. There's a much higher rate of CMV reactivation when the donor is positive. That implies that somehow that's a viral load transfer effect, at least to me it implies that. Is there any way of measuring that? Is there some way of measuring how much CMV is present? Maybe one of the predictors of who's going to get reactivation is not just donor positive versus negative, but maybe there's degrees of donor positivity. And one of the advantages of EVLP, maybe it could be by time to do tissue biopsies or some other measure of the viral load being transferred.
Yeah, for sure. That's an excellent question. So first thing, about 2/3 of reactivation of CMV is donor-derived, so from this donor seropositive organs. The other 1/3 is from the recipient that is positive. But going into the question of detecting and measuring latency, that's actually something that I've tried in the past 5 years, and it's really, really tricky. A lot of other places are trying to do that, but there is no validated and really good assay to actually quantify latent CMV. So we at this point we do not have a measurement of kind of stratifying these donors into maybe a higher latent burden and lower. So, and this really happens because latency, what's known from recent studies is that it is, so it's latent but not in the sense that it's silent, it is, but it's just, so there is gene expression, but in a really low grade. So it's really hard to detect. So that is the main issue, and that's something I've been trying, other centers have been trying, and unfortunately, we're still not there.
Do you have time for one more? Or you...
Go for it.
Okay, so the last question is about the idea that inflammation is inflammation is inflammation. And, you know, obviously that's not true. Is there something unique about the donors that have high IL-7, IL-12 as a kind of cytokine signature that's somehow characteristic that perhaps could be evaluated just on clinical criteria as opposed to actually doing an expensive test to measure those cytokines?
That's a good question. And again, this is all new territory, and even CMV, like even the basic science around it, there's a lot still to be elucidated. So honestly, not too sure for now. It's really trying to validate it, having a higher end here and seeing if this biomarkers actually turn out to be predictive somehow of CMV reactivation, and further elucidate even in like in vitro type of studies to see really what's the mechanism behind it. But I don't know if there's anything that we could measure that would be less a bit costly that would reflect specifically IL-7 and IL-12.
Thank you very much.
Thank you.
I'd like to invite Shelley Liu up to the podium. She will be presenting loss of tumor suppressor FAM46C induces K-ion channelopathy and progression of gastric adenocarcinoma.
Thank you, Dr. Haas, for the introduction. And additionally, thank you to the GallieDay Selection Committee and organizers for the opportunity to present our work. Sorry, oh, there we go. So gastric cancer is the third leading cause of cancer-related death worldwide. And despite improvements in surgical technique and perioperative adjuvant therapy, gastric cancer continues to carry a very poor prognosis amongst patients in Canada, as you can see here. So as a result, there is considerable interest in trying to identify biomarkers or therapeutic targets that drive gastric cancer progression. And one such candidate of interest is polo-like kinase 4, or PLK4. Our group has previously shown that PLK4 regulates breast cancer cell migration, invasion, and metastasis. And dysregulation of PLK4 expression is intimately linked to cancer, and change in its expression, whether up or down, can be found in multiple epithelial cancers, including glioblastoma. However, PLK4, its role is unclear in gastric cancer. So as a result, our first research objective was to interrogate the status of PLK4 expression and its interactors in gastric cancer. And in order to do this, we created the Gastric Cancer Biobank across Mount Sinai Hospital and UHN. We identified paired tumor and normal blocks from surgery. I manually microdissected the tissues under the guidance of a GI pathologist. We extracted RNA and performed real-time reverse transcription PCR analysis. So from 2001 to 2017, we identified 256 consecutive curative intent gastric adenocarcinoma resections across both institutions. And as Miguel alluded to earlier, dealing with poor quality genetic material is something that we encounter with archival tissues, and indeed we encountered this in 23 cases. But in fact, we were actually more hampered by missing tissue blocks. All in all, we had 158 patients in our final cohort. So the clinical pathologic factors of our study cohort are presented here. Fairly typical for a North American cohort, and the median follow-up was 32 months. So when we queried the expression of PLK4 in our cohort, we found that unlike in breast and colorectal and CNS cancer, PLK4 expression was not significantly higher in tumors compared to normal mucosa. And in fact, its expression was not correlated with clinical pathologic factors or outcome. At this point, we turned to an examination of the rest of the PLK4 interactome, which consisted of 55 interactors that our group had previously identified. And in fact, our group had shown that one such interactor, the ARP2/3 complex, mediated breast cancer cell movement. And ARP2/3 was overexpressed in our gastric cancer cohort as well, but it did not correlate with clinical pathologic factors or outcome again. What did prove to be of interest, though, was FAM46C, a PLK4 kinase activity inhibitor. We found that it was vastly underexpressed in our 158 patients, where 94% of patients exhibited depleted FAM46C expression in their tumors compared to normal mucosa. So this piqued our interest as a possible biomarker. We split our cohorts into low versus high FAM46C expressors using the median expression in FAM46C of tumor over normal mucosa. And we found that indeed retention of FAM46C was associated with superior disease-specific survival, as shown here by the high FAM46C group. Furthermore, the prognostic significance of FAM46C persisted in patients with aggressive disease, as seen in this node-positive subgroup of 102 patients. And on multivariable analysis, low FAM46C was an independent prognostic factor for inferior disease-specific survival in our cohort, along with proximal tumor location and stage 3 disease. So at this point, having identified FAM46C as a biomarker of survival in our cohort, we decided to investigate FAM46C as a potential tumor suppressor in gastric cancer. We investigated FAM46C's role on tumor growth in vivo, and to do this, AGS gastric cancer cells with a FAM46C knockdown or GFP control knockdown were injected into mice, and indeed the FAM46C knockdown persisted in the tumors that grew. And we found that FAM46C suppresses AGS mouse xenograft tumor growth and invasion, suggesting that it is a tumor suppressor in vivo. So then we considered the potential functions by which FAM46C could act as a tumor suppressor. As I mentioned earlier, FAM46C is a PLK4 kinase inhibitor. In the multiple myeloma, very recently as well, it's been identified as a poly-A polymerase and also to regulate autophagy. Its role as a PLK4 inhibitor was especially attractive, as very recent work in our lab had shown that PLK4 promotes migration in gastric cancer in vitro. So we hypothesized that as a PLK4 inhibitor, FAM46C could also suppress migration. And indeed, it was the case. In a scratch wound assay of FAM46C depleted cells of gastric cancer, we see that there is increased cell migration. And similarly, in a transwell invasion assay, FAM46C knockdown gastric cancer cells exhibited greater invasion. So all in all, this suggests that FAM46C suppresses gastric cancer cell migration and invasion, possibly through PLK4 inhibition. So at this point, to tease out the relationship between FAM46C, PLK4, and cell migration, we utilized Centrinone B, a specific PLK4 activity inhibitor. We demonstrated that Centrinone B treatment inhibits gastric cancer cell migration through PLK4 inhibition without effect on FAM46C expression or cell viability. And interestingly, when we applied Centrinone B to FAM46C depleted cells, it impaired their cell migration as expected, but it did not impair it to the level of untreated SI luciferase control, suggesting that perhaps FAM46C's effect on cell migration is not exclusive to PLK4 inhibition. So this leads us to our third objective, which is to investigate other downstream mediators of FAM46C. And in order to do this, we took an unbiased approach and performed RNA sequencing in 21 patients' tissues, fresh frozen tissues that we had banked ourselves. And similar to previous, we split this cohort into low versus high FAM46C groups using the expression median. And we performed differential expression gene analysis for both groups separately. Here's a volcano plot for the low FAM46C group. And the low FAM46C group was ultimately of interest to us because in enrichment analysis, functional clustering of Go terms revealed that there was significant dysregulation of ion channel-related pathways only found in the low FAM46C group and not in a high FAM46C group, suggesting that loss of FAM46C could result in ion channelopathy. So at this point, we selected 7 ion channels for further study. We validated expression of each of these ion channels, which had been named in the differential expression gene analysis in gastric cancer cells with the FAM46C knockdown. And ATP4A, CLCN2, and KCNQ1 expression was decreased in the FAM46C knockdown cells, suggesting that their expression was positively correlated with FAM46C. KCNQ1, the main potassium recycler in parietal cells, was explored further. And we went back to our patient gastric biobank, and we found that KCNQ1 was underexpressed in tumors compared to normal mucosa for these patients. And furthermore, in the patients, their FAM46C expression was correlated with KCNQ1 expression. So finally, we investigated KCNQ1's ion channel function in gastric cancer, and in order to do this, we subjected FAM46C knockdown gastric cancer cells compared to control to high potassium chloride concentration media, and we found that FAM46C knockdown cells were better able to tolerate a high potassium chloride concentration media, suggesting that perhaps loss of the tumor suppressor FAM46C pathway results in a better ability to tolerate a hostile microenvironment characteristic of solid tumors. So all in all, in summary, we identified FAM46C expression as a novel biomarker of survival in our cohort of 158 patients. I demonstrated that FAM46C suppresses gastric cancer progression, both in vitro and in vivo in our gastric cancer. And also, we explored a possible relationship between FAM46C and KCNQ1 and resultant ion channelopathy. So this suggests potential for FAM46C as both a biomarker and also a therapeutic target, where activation of FAM46C could be considered in patients with aggressive disease and gastric cancer. So I'd like to acknowledge my supervisor, Dr. Swallow, and also our collaboration with Dr. Darling and Dr. Young Lab. Thank you very much.
That was beautifully presented. We will be joined by Dr. Natalie Coburn, I think virtually, for the discussion.
Yeah, thank you, Shelley. That's an amazing amount of work, really tour de force in examining this really important cancer. I have some questions about determination of the cut point. So when you have lower levels of the FAM46C, there seemed to be quite a spread on that in your first cohort of the 158 patients. Did you look at other mechanisms for determination of high versus low, or cubic splines or quantiles, or even a continuous to put into your model to see if there's more of a dose response curve? Because it didn't seem like there's a clear cut point of high versus low.
Yeah, so we used a median because there was no available cutoff in the literature, so that was an easy cutoff to begin with. We have explored since then whether we can do different quartiles or whether we should do a continuous kind of determination of FAM46C with our biostatistician. We haven't found a better cutoff than median, so for now it shall be our median. But we are hoping that we can validate these results in a separate cohort, and with a larger sample size, we may be able to refine our cutoff.
Okay, thank you. Second question, when you looked at your models, you don't talk about some of the things that I would think of clinically as classically important for gastric cancer survival, like MSI status or HER2 status. So how does that interact with the FAM46C and the polo-like kinase?
Yeah, that is something that actually plagued my work a little bit. Unfortunately, I didn't have access to the classical TCGA analysis of our cohorts. Its MSI status as well has not been determined for the majority of our cohort, simply because it was not clinically indicated at the time that these resections were done. So I can't really draw any conclusions with regards to FAM46C and MSI. But I did look in the TCGA database, and I did find that EBV positive tumors tended to have a higher FAM46C level for reasons unknown. And I think that may provide a clue with regards to possible relationship between FAM46C and MSI status as well.
Yeah, because you have the 6% where it's not downregulated. Did you look at that 6% to see if they were EBV or MSI or some specific phenotype or genotype, I guess?
Sorry, I missed the first part of your question. 60% were...
You have the 6% that don't have lower levels of FAM46C. Is there anything special about that 6%, or were you able to examine that?
Oh, I see. So that's an interesting question. The 6%, we didn't see anything specific to correlate with them. I also, unfortunately, I think we only had MSI status for 10% of our patients out of between 2001 to 2017. So again, I couldn't make any solid conclusions there.
It's congratulations. It's a tremendous amount of work. Thank you.
Thank you.
And rounding out a truly spectacular afternoon, we have Michael Ballas, who will be presenting early discharge after uncomplicated elective colectomy is associated with lower risk of post-discharge complications.
Hello, everyone. I recognize I'm the last one presenting today, so not to worry. This will only take an hour. My name is Michael Ballas. I am very excited and honored to be presenting among all of you distinguished speakers today. And I'd like to take a moment to thank the amazing team and mentors I've been working with and who have made this possible, especially Dr. James Jung sitting over there. So without further ado, early discharge after uncomplicated elective colectomy is associated with lower risk of post-discharge complications. I have no disclosures of interest. So patients undergoing uncomplicated elective colectomy, or UEC in North America, are increasingly being discharged after shorter hospital stays. We're pushing them out of the hospitals, and naturally there are concerns with this. Is there adequate monitoring? Are there higher risks of complications? Is it safe, fundamentally? That's the question we want to know. And sorry, I can't see my slides. And does this require more overall healthcare utilization? Are we pushing patients out today just so that they'll come back 10 days later with 3 additional complications? So to formally address this, our objective is to determine the relationship between discharge timing and post-discharge safety in adult patients undergoing uncomplicated elective colectomy. Our data source is the American College of Surgeons National Surgery Quality Improvement Program, or NSQIP, the database from 2012 to 2019. It collects over 250 patient and hospital level variables across more than 700 sites in North America. The data is reliable because it undergoes both internal and external audits by trained data abstractors, although unfortunately surgeon, facility, and geographic identifiers are not available for us to use. In regards to our study eligibility, we're including adult patients aged 18 to 90 undergoing uncomplicated elective colectomy with general anesthesia. We're excluding patients with postoperative ileus or anastomotic leak because unfortunately those variables are missing information on the time to event, so we don't know when they occurred. We're also excluding inpatient complications and emergency surgeries because they're outside of the scope of our research question, and likely they wouldn't be suitable for early discharge anyway. And we're also excluding patients with missing data. And that leaves us with our final study cohort, and it's important to mention that all included patients are followed after discharge for 30 days using the NSQIP data. These are all of our patient covariates. There's a lot of them. Demographic ones include age, sex, race. We also have data on health covariates, like whether they have dyspnea, are they dependent on a ventilator, etc. We have information on their comorbidities, like whether they have ascites, disseminated cancer, etc. And finally, we also have information on their surgical covariates. We have information on their seasonal quarter of admission, the total operation time, the number of days from hospital admission to operation, as well as the surgical indication. And we group those into 4 categories: acute, malignant, chronic diverticular disease, and other, which encompasses non-malignant polyps or any other condition. For our outcomes, the primary one is the occurrence and number of days from discharge to any post-discharge complication, and our secondary outcomes are the occurrence and number of days from discharge to a post-discharge serious, non-serious, surgical, and medical complication, as well as a return to the OR. And it's important to mention that these bolded words are composite outcomes. They're aggregates of complications that were defined by the American College of Surgeons Risk Calculator, as well as previous studies that aggregated complications in similar groups. So for example, we see that a patient who has a cardiac arrest will be listed as having any complication, a serious complication, and a medical complication. For our statistical analysis, we took our entire NSQIP database and we stratified it according to our 3 surgical approaches: laparoscopic, robotic, and open surgery. And then for each of these approaches, we further dichotomized these groups into early and delayed post-discharge groups. For laparoscopic and robotic surgery, the threshold was 3 days, while for open surgery, this threshold was 4. To investigate the effective timing on the occurrence of a complication, we performed propensity score matching to reduce the covariate imbalance between discharge groups. And then after successfully matching the groups, we performed unadjusted logistic regression to determine the average treatment effect of discharge timing on the occurrence of a complication. And the reason it's unadjusted is because we've already balanced between covariates between the two discharge groups. To investigate the effect of discharge timing on the number of days to a complication, we plotted Kaplan-Meier survival curves using the matched cohorts, the propensity score matched cohorts, and the log rank test to compare the survival curves and ensure that there's a significant difference between groups if there is one. We also built univariate Cox proportional hazards model, again univariate because we're using the propensity score matched cohorts to estimate the relative change in the hazard of complications, and we grouped these using the Nelson-Allen estimator. And here we can see the concert flowchart of our study population. We started with about 260,000 patients, and then after filtering by various exclusion criteria, one of them highlighted showing that only less than 2% of patients were actually missing data, we're left with about 114,000 patients in our final cohort, 78,000 of which were in the laparoscopic group, 16,000 in the robotic surgery group, and 20,000 in the open surgery group. After dichotomizing each surgery group into early and delayed discharge groups, we see that slightly more than half had early discharge in the laparoscopic group with 55%, 65% in the robotic group, and slightly less than half had early discharge in the open surgery group at 43%. We also saw that patients being discharged early across all three surgical approaches were more likely to have a shorter operating time and a lower ASA class, which is unsurprising. And we also see other distinct features for each surgical approach. For example, in laparoscopic surgery, they also tended to have non-acute surgical indications, lower rates of chemotherapy, and lower rates of chronic steroid use if they were discharged early. And obviously, if we leave these biases in, it would affect the results of our analysis, which is why we performed the propensity score matching to ensure that early and delayed discharge groups are balanced. And they were, and these are the results of our balancing. You can see, comparing the matched to unmatched group density plots, the early and delayed discharge groups have much greater synchronicity in the matched cohorts, and numerically, we see that all covariates standardized mean differences were less than 0.1, indicating that all covariates were successfully balanced across all three surgical approaches. Now investigating the effect of discharge timing on the outcome of any complication, we see that patients that were discharged early had 27% lower odds of having any complication compared to their later discharge counterparts in the laparoscopic surgery subgroup. 37% had lower odds in the robotic group, and 9% had lower odds in the open group, although this was non-significant. If we expand these results to all secondary outcomes as well, we see the same patterns. In the laparoscopic and robotic groups, patients that were discharged early had 20 to 30% lower odds of having any complication, a serious, non-serious surgical and medical complication, and all of these were significant. Whereas a return to the OR, although the odds were still lower, the significance, it was non-significant. And again, for open surgery, the odds were lower, although still non-significant. Here we see the Kaplan-Meier survival curves for each of the surgical approaches, the early discharge group in blue and delayed in red, and we see consistently over that 30-day follow-up period, patients in the early discharge group have lower complication rates, and the log rank test shows that the difference between those survival curves is significant in the laparoscopic and robotic groups, while non-significant in the open surgery group, and you can see the confidence intervals touching near the end there. And again, our Nelson-Allen hazard curves are showing essentially the same thing, only inversed. And again, for laparoscopic surgery, we see that patients in the early discharge group had 27% lower hazards of having any complication compared to patients in the delayed discharge group. And these patterns remain evident across all other secondary outcomes as well. So to conclude, early discharge for uncomplicated elective colectomy is not only safe, but also associated with a lower risk of post-discharge complications for patients undergoing minimally invasive surgery, so robotic and laparoscopic. And our analyses suggest that surgeons and healthcare systems practice sound clinical judgment when selecting patients for early discharge. So once again, I'd like to thank you all for listening and thank my wonderful team for all the great help they provided, and open the floor to questions.
And I'd like to invite Dr. Paul Kerr-Nicholas to discuss this great paper.
Okay, thank you. I'm also virtual. Apologies. Yeah, I'm up here in virtual land. Hi, Michael. Great presentation and congratulations on the work. I think it's really important, as you said, there's a huge push to discharge patients earlier and earlier, really due to health system reasons. And I think it's important to make sure that in so doing, we're not harming patients in any way. So I think this is really important work. I do have 3 questions. The first has to do with your underlying hypothesis in terms of assessing patient safety, and you chose to do that predominantly by looking at incidence of complications. And I just question the rationale for thinking that incidence of complications might differ based on timing of discharge. It seems to me that the incidence of complications is likely stable irrespective of timing of discharge, but it's the ability to rescue those complications when they occur that likely differs if there is a difference between groups. And so, you showed a difference in favoring the early discharge group in anything based on incidence of complication and time to complication. However, there's likely still residual confounding there. So I wonder, isn't the issue more about rescuing patients who do have complications? So did you look at the severity and the impact of complications when they occurred between the groups at all?
For your question, I had a bit of trouble hearing. I don't know if it's the acoustics in this room or the connection. Would you mind just rephrasing the last part of your question, summarizing it really quickly?
Sure. So the question is, did you look at outcomes of complications when they occurred rather than simply incidence of complications between the groups? So it's the concept of failure to rescue, missing the opportunity to rescue a patient from a complication if they've been discharged early.
I would agree. I think the main point of the paper is just to ensure that patients that are discharged early aren't sent early and are experiencing any complications that would necessitate their return to the hospital and in the end increase overall healthcare utilization, and ensure that if they were discharged early, if a complication were to occur, obviously you don't want it to occur out of the hospital. So it was just outcomes. It wasn't necessarily incidents, but that's certainly something we could investigate in future papers.
Okay, great. The second question I had was having to do with trends in time. You looked at a fairly long time frame, I believe 8 years of time in which there was likely a move towards earlier discharge. Did you look at what happened over time in terms of incidence of complications and timing of discharge?
We actually I believe we used year as a covariate in the model, so to ensure that over time as practices change, that wouldn't be biasing our results. But I don't recall seeing any major patterns in terms of complication rates and discharge timings between 2012 to 2019.
Okay, great. And final question, Michael. Discharging patients early and making sure it's safe is one part of the equation. The other has to do with patient experience. And I think a lot of people have questioned whether the push to early discharge is something that really helps patients overall. It may be better for the healthcare system, but I think it's unclear whether it's better or worse for patients and their families. I know that data is not available in NSQIP, or at least in prior versions, although there's talks about having more patient-reported outcomes in it moving forward. I guess it's a philosophical question. What's your perspective on that? Do you have plans to study that further, or what's your perspective just from reading other literature about that?
I would say that the overall overarching goal and purpose of our study was to just make sure there weren't any red flags when it comes to discharge. And I think we found that we could be fairly confident and reassured that when we are discharging patients early, that we are doing so in a way that's not only safe, but improving their complication rates. But I also agree that we don't know exactly why some patients are being discharged later and why others aren't. We don't have that data in NSQIP, and that is certainly something we're looking forward to studying in the future. Why are doctors making some patients discharged after 5 days rather than 2 days, even if we're balancing covariates?
Wonderful. Great job. Thanks, Michael.
Thank you.
We have one more question from Dr. Waddell.
Enjoyed it as well. So you said 2 days versus 5 days. My question was actually going to be, in your data, you looked at less than 3 days or more than 3 days. So theoretically, like if you were to go to a old general surgeon, say all your patients stay 5 days, we've got this new program, we want you to send them home. At 2 days, you might see very different kind of results. Did you do any sensitivity analysis where you looked at the more extreme versions of early and late rather than just dividing at that midpoint?
That's a great question, thank you. We didn't perform any sensitivity analyses looking at the extremes of any discharge rates. We chose our thresholds based on expert opinion, and it was close to the median of discharge. We did perform a sensitivity analysis looking at whether the actual surgical indication was an issue, comparing malignant to non-malignant indications, and there weren't any differences. The results were still significant. But looking at the extremes, I think, would be also a worthwhile sensitivity analysis to add on. So thank you, we'll look into that.
Fantastic work.
Thank you.
And now for closing remarks.
Well, it's been quite the day, and thanks everybody for staying until the end. It's been wonderful to have an in-person meeting, I guess our first in the past 3 years. So a big thanks to a number of people. So to Val Cabral and to Sylvia for the logistics and all of the organization, to our IT team. So thank you very much. Andrea McCart had a big role as well in terms of coordinating things in our research committee. A big thanks to Dr. Rutka for his support. Fantastic a talk by our Gordon Murray lecturer, Professor Peter Hutchison. So Hutch, thank you very much. And thank you also to Drs. Aaron Nauth and to Barbara Haas for moderating duties in the morning and in the afternoon. I know it was a bit of a marathon session in the morning and the afternoon, but both of you did very well in terms of fielding all of the questions. Fantastic presentations by all of our students and trainees. So I think that was really a big highlight of the day. And then the trauma session I thought was very special. So I think on that note, I think we'll close out our 2022 GallieDay and hope to see many of you at dinner tonight.